Hello, good evening everyone. Hi, this is Dr. Anil Mirchandani. I welcome you all for the session on early pregnancy and its complications. So from today onwards, we are going to talk about obstetric topics. There are many obstetric topics pending. And yes, my dear friends, so the topic is early pregnancy and pregnancy complications. We will be talking about the physiology pack. The fertilization, the implantation, the problems in fertilizations and implantations. And then we will also talk about abortions, ectopic, molar pregnancy, and gestational trophoblastic neoplasia. So I hope everyone is online. I hope everyone is able to hear me and see me. Okay, hi. So everyone, yeah, thank you so much, Asha. Yeah, so it's nice to be here on my birthday and taking your lecture. So today's plan is we will be talking about four things: early pregnancy, that's physiology, and then abortions, ectopic, and molar pregnancy and gestational trophoblastic neoplasias. So abortion, ectopic, molar, GTN, and early pregnancy. 5 topics are there. So without wasting time, let's begin our session. And in this session, we are going to talk about the questions. Okay. Good evening. Hello. Thank you so much, my dear friends. Thank you so much for your lovely wishes. So let us begin, yeah, without wasting time. So the question is, assertion: only one sperm can enter the secondary oocyte. Only? Asha is asking, why are you here today, sir? Asha, unfortunately, I have a very tight schedule. I am flying to Chandigarh day after, and tomorrow also there is some schedule, and then I have a full tight packed schedule till October 31st. So that's why I have to complete. I have a responsibility, and that's why I have to be here to finish off the topics which are assigned to me. Okay, so I know, but that's like, chalo, Asha, this one is for you. Acha, Asha, you asked me some question. Okay, I have to give you a reference of Samson's artery, right? Round ligament artery, Samson's artery. I'll give you. It is given in Williams also. And regarding Mullerian and UGS, right, Asha? Okay, so I'll give you the reference. I totally forgot. Just saw your name and then I realized that I had promised you to show you the reference. Okay, chalo. Only one sperm can enter a secondary oocyte. Reason: zona functionalis prevents multiple entries due to zona block. Come on, think. Is the assertion correct? Is the reason correct? And if the reason is correct, is it the correct reason of this assertion? So what do you think is the right answer? Assertion is correct and reason is correct explanation. Is this the right answer? Assertion is correct and the reason is incorrect explanation of assertion. Assertion and reason both are incorrect. Assertion is incorrect reason and incorrect, and reason is correct statement but incorrect explanation. So what do you think is the right answer? Is this a zona functionalis which prevents the multiple sperm entries? No, it is not zona functionalis. It is zona pellucida. Agreed? There is a zona pellucida. Okay, that is the reason which prevents multiple entries due to zona block. You must be knowing that secondary oocyte has a life of 12 to 24 hours. It should get fertilized on the same day of ovulation. If it doesn't get fertilized, then it will undergo atresia. Yeah. So secondary oocyte will have to be fertilized, and the most common site of fertilization is ampulla. Yeah, most common site of fertilization is ampulla. And then there is a zona pellucida which prevents two things. Zona pellucida prevents a triploidy or triploidy. Yeah, if two sperms enter inside, then there will be triploidy. B, ectopic pregnancy. Now think about it. If two sperms enter inside at the same time, then there will be triploidy. This will be called as partial mole pregnancy. So zona pellucida prevents partial mole pregnancy as well as ectopic pregnancy. This zona pellucida does not dissolve in fallopian tube. Yeah. So this is about zona pellucida, and yes, it prevents multiple sperm entry. Now few more factual things about fertilization and implantation, what you should know at your level. Now, as I told you, fertilization is happening most commonly in ampulla. So there will be a zygote formed in ampulla. It will undergo first cleavage. It will take 30 hours. Yeah, and there will be 2 cell stage formed. 2 will become 4, 4 will become 8. 8 is called as early morula. Yeah, 8 is called early morula. Now this 8 will enter into the uterus as 16 cell stage. Yeah, 16 cell morula enters uterus. 16 celled morula enters uterus. Still there is a zona pellucida all around, and this is day 4 of fertilization. Day 4 of fertilization, this is going to happen, right? Now understand this thing that day 4 of fertilization is morula formation. 16 cell morula entering into uterus. Day 5 is the day when morula changes and becomes a blastocyst. It becomes a blastocyst where there will be outer cell layers, outer cell layer called trophoblast, and inner cell mass called embryoblast. Yeah, trophoblast, embryoblast formed on day 5. Yeah, day 4 of fertilization is entry into uterus. Day 5 is blastocyst formation, and zona pellucida gets dissolved in 2 days of entering into uterus. So it will dissolve in coming 2 days of entering uterus. That means dissolution would happen on 6th day, right? So implantation will happen. Implantation is 6 to 7 days after fertilization. So if 1st January is her LMP, 14th January ovulation, if 28 day cycles are there, and the same day would be fertilization, 21st January would be the day of implantation. Yeah, implantation 21st January. 22nd January HCG is formed. So HCG is formed on 22nd of January. We will get to know HCG by UPT on 29th of January when she will report to us that, doctor, I have missed my period. 29th January would be day 1 of missed period. Yeah. So that would be 29th day of LMP, which would be 15th day of fertilization as UPT positive, urine pregnancy test positive. But if you get a question, most sensitive HCG investigation. What? I said most sensitive HCG investigation. The new answer is FIA followed by RIA, full formed as fluorescence immunoassay, and then is radio immunoassay. Yeah, radio immunoassay. Yeah, most sensitive HCG investigation is FIA followed by RIA. You will be able to do these quantitative investigations. UPT is a quality test. FIA, RIAs are quality tests. And we can do these things even before the missed period, especially in IVF pregnancies. Yeah, when we want to know whether IVF is successful or not, we can do these things. Generally, we rely on UPT. UPT is positive on day 1 of missed period. Yeah. If you get a question, implantation site, the answer would be posterior wall near fundus. Yeah. Posterior wall near fundus. That's the most common site of implantation. Implantation stage is blastocyst. Implantation sequence would be a position, adhesion, penetration. A position, adhesion, penetration is the sequence of implantation. Implantation gets over. So when is the time when you will find that implantation is over? Implantation gets over on day 10, 11 of fertilization. Yeah, implantation gets, these are simple one-liners which are oftenly asked in exam, especially the exams which are conducted by NV. Yeah, so these are simple one-liners which you should know by heart regarding fertilization and implantation in early pregnancy. Yeah, so posterior wall near fundus, blastocyst, apposition, adhesion, penetration, day 11 of fertilization, it gets over, day 10, day 11. Yeah, got it? Now, some clinicals. Now, there are some USGs which will show you the signs of implantation. Yeah, they will show you the signs of implantation. I want you people to look at these pictures of implantation sites and signs. You know that there is something called a triple line endometrium. Triple line endometrium is seen in mid-cycle. Now, this is a picture which is showing a uterus, the endometrium, and you are seeing a gestational sac. This is implantation. This is a blastocyst which got implanted. This is called an intradecidual sign. This is earliest sign of implantation. Earliest sign of implantation is this sign called intradecidual sign. Yeah. Then after intradecidual sign, there would be something called a double decidual space sign. So uterus will develop two rings like this. There will be two cavities, cavity A, cavity B. Yeah. This is called as double decidual space or sac sign. Double decidual sac sign. Let me draw a diagram of uterus over here. Yeah, and this is the endometrium over here, and there is a ball over here. Yeah, there is an implantation which has happened on the posterior wall near fundus. So there is something called decidua basalis, DB. Yeah, there is something called decidua parietalis, DP. And then the decidua which covers this ball called zygote is called decidua capsularis. We all know this. Decidua basalis, decidua capsularis, decidua parietalis. And because of these three deciduae, uterine cavity will be subdivided into two cavities. One will be between basalis and capsularis. Yeah. And another cavity between capsularis and parietalis. This is called a double decidual space sign. Yeah. Double decidual space sign. So one was intradecidual, which was earliest. And once the zygote grows, there will be double decidual space sign. Now, in this ball called zygote, this blastocyst, there's going to be formation of embryonic disc. Yeah, there's formation of embryonic disc, and that is why there are two cavities. One is called amniotic cavity and another is called yolk sac cavity. This will happen slightly later on. Yeah, after these two signs which are written, there will be a sign called as double bleb sign. Because of formation of embryonic disc, as you can very well see, there are two distinct sacs. Yeah, double bleb sign. This picture is dedicated to yolk sac. So double bleb sign, which means formation of yolk sac and amniotic sac. Yeah, yolk sac and amniotic sac visible. That is why it is called double bleb sign. Now from this embryonic disc, there will be foldings and there will be formation of embryo. So this picture is when the baby has enlarged. This is that amniotic cavity where the baby has now grown, and you can see the cranial end and the caudal end. Yeah, you can see these limb buds also. Yeah, you might see a cardiac activity as well. The distance between the caudal and the cranial end is very famously called as crown rump length. You all know this. CRL, crown rump length. And in this you will see a cardiac activity in few days. So sequence wise, there is a gestational sac, then comes yolk sac, then comes crown rump length, and finally there will be cardiac activity. Agreed? G-sac, yolk sac, crown rump length, cardiac activity. Out of these, G-sac obviously will be the first thing. It will be seen on 29th of January. That means I would write 4 week, 1 day, to 4 week, 3 days. Yeah, G-sac would be seen by this time. Yeah, cardiac activity is generally seen in the 6th week. Cardiac activity is seen in the 6th week. I am talking about transvaginal sonography, TVS. Yeah, cardiac activity is seen in the 6th week. Am I clear about this, guys? So right from fertilization I have covered till implantation and the formation of G-sac, yolk sac, crown rump length, and cardiac activity with their clinical effects, clinical manifestations. Yeah, there are many questions. You will face these questions for sure in your exam. So let us talk about these questions. Are you all there? Suddenly ऐसा क्यों लग रहा है कि सब लोग गायब हो गए? I hope you are all there. Okay. So here you are right. Zona functionalis has nothing to do. Zona pellucida is the thing which is responsible for prevention of multiple sperm entries. Okay. Next question. In the first trimester, USG is done. Arrange the following in correct sequence. Just now we have done this question. Which is the first thing which you are going to see? I have just now told you, a gestational sac. फिर क्या देखेंगे? Yolk sac. फिर क्या देखेंगे? Crown rump length. And finally क्या देखेंगे? Cardiac activity. We will see cardiac activity as the last event in this early pregnancy. Yeah. So you must be knowing that we do first trimester USG between 7 to 9 weeks. First trimester USG between 7 to 9 weeks. It is called as dating scan. Yeah. First trimester USG 7 to 9 weeks. Dating scan कहते हैं उसे. Okay. Now, why it is called dating scan? Because gestational age is accurately measured. Yeah. The error is minimum. Error is just 3 to 5 days. Underline 5. And the best parameter is CRL, crown rump length. Yeah, best parameter is crown rump length. This is first trimester USG. In first trimester we also do one more USG, and that is done between 11 weeks to 13 plus 6 weeks, and the name is known to everyone. It is called as NT scan, nuchal translucency scan. The figure has changed. It was 3.5 millimeter. Now is a 3 mm is the cutoff for screening positive. NT scan is 3 mm cutoff for screening positive. Then in second trimester, we do sonography called as booking scan. It is done between 18 to 22 weeks. It is also called as TIFA. TIFA means targeted imaging for fetal anomalies. Targeted imaging for fetal anomalies. Yeah, that's booking scan. By the way, best parameter for gestational age in second trimester would be, yes, anyone? Best parameter for gestational age. If this question is asked to you, best parameter for gestational age in second trimester, what will be your right answer? Anyone? वैसे तो crown rump length, because first trimester is the best trimester for gestational age assessment. In fact, it is more accurate than even Negley's formula. Yeah, Negley's formula has its own errors. This is most accurate. First trimester scan. You tell me, which is the best parameter for a second trimester? Yes, tell me. The correct answer is biparietal diameter, BPD. Best parameter for gestational age in second trimester is biparietal diameter, BPD. Correct. What will be the best parameter for gestational age in third trimester? Options: CRL, BPD, FL or AC. Femur length or abdominal circumference? Yes, you tell me. Third trimester, femur length or abdominal circumference? Best parameter for gestational age in third trimester is none other than femur length. FL, femur length is best. Yeah, correct, very clear. Regarding the growth in third trimester, growth scan depends upon abdominal circumference. That's a third trimester scan predominantly. If the uterus is not matching with period of gestation, we always do sonography. And then abdominal circumference is the best parameter for the growth of the baby. If you are talking about gestational age, then femur length. If you are talking about growth of the baby, then abdominal circumference. So if you get a question, most sensitive parameter for IUGR or macrosomia, the answer would be none other than abdominal circumference. Am I clear about this? Most sensitive parameter for IUGR or macrosomia would be abdominal circumference. Am I clear about this? Okay. Alright. Let us jump on to the next question. 22-year-old Primi Gravida has undergone ultrasound. The single intrauterine gestational sac, that means double bleb sign is there. Okay. 20 millimeter gestational sac size is there. Okay, fine. Yolk sac is also there. Okay, double bleb there. Yeah, double bleb. So yolk sac 3 millimeter. But cardiac activity is not visualized. The diagnosis is. What is your plan? What is your diagnosis? Is it ectopic pregnancy? Is it non-viable intrauterine pregnancy? Is it early gestation requiring follow-up? Or it is threatened abortion requiring progesterone support? What will you do with this patient? Question number 3. Come on, Asha, Radhika. Tell me. Yeah. Radhika has joined after many days, I presume. Okay. Great. So yes. Congratulations, Radhika, for topping in your university. I saw your video. Somebody sent me. Chalo, tell me. What's your right answer? The correct answer is early gestation requiring follow-up. Yeah, this is the correct answer. Why? Because gestational sac is still 20 millimeter, yolk sac is still 3 millimeter. That's okay. Yeah, remember this thing. Critical cutoff to visualize crown rump, to visualize cardiac activity is crown rump length of 7 millimeter. Crown rump length of 7 millimeter. If it would have been 7 millimeter and no cardiac activity, I would have told you to diagnose it as non-viable pregnancy. It is less than 7, so the treatment is, best treatment is repeat. For this case, best treatment is repeat USG in 7 days. Next week, we will do sonography again and let us see whether cardiac activity comes or not. Yeah. If let's say it is 13 millimeter now. Yeah. Okay. Here it is yolk sac. Now I will change it, please. This is not yolk sac. This is crown rump length. I will change that question. This is crown rump length of 3 millimeter. Yeah. So crown rump length 3 millimeter, you have to wait. Yeah. This is not yolk sac. This is crown rump length of 3 millimeter. Okay. Okay. So best is USG in 7 days. That would be the best approach. Second best approach is beta HCG, 2 values 48 hours apart. That is another approach. Not the best approach, obviously. Yeah. The rule is beta HCG should increase by 55% or more for a healthy intrauterine pregnancy. Some books have written 53, some books have written 55. Yeah. Beta HCG should increase by at least 55% or more for labeling it as healthy intrauterine pregnancy. But don't you think we'll have to call her up again for doing sonography? Cardiac activity aaya nahi hai na? Patient will be restless, you will be restless. So you'll have to call her up again after 7 days for repeat sonography. The critical cutoff is 7 millimeter. Okay, not 10. It is 7. Now, one more line over here, one more MCQ over here. Critical cutoff. To visualize crown rump length, यानी कि poles. Critical cutoff to visualize poles. That means embryo दिखने के लिए poles चाहिए. Poles के लिए crown rump length. And उसका critical cutoff है gestational sac 25 millimeter. Gestational sac 25 millimeter होना चाहिए. I mean, gestational 25 के अंदर होना चाहिए. अगर 25 टच किया, if there is 25 value and still you are not seeing crown rump length, it is an embryonic pregnancy. I will repeat, GSAC 25 millimeter or more with no poles is non-viable. Yeah, it's a non-viable pregnancy. It is called as an embryonic pregnancy. Yeah, an embryonic pregnancy. Got it? Very clear? GSAC 25 millimeter with no poles is non-viable. Okay. Similarly, there is one more line like this. Critical cutoff. To visualize. Critical cutoff to visualize a yolk sac. Yeah, is gestational sac 10 millimeter. Gestational sac 10 millimeter, you should see a yolk sac. If there is a gestational sac of more than 10 millimeter in the uterus, there is a gestational sac of more than 10 millimeter. No yolk sac. Yeah, this is more than 10 millimeter. Yeah, with no yolk sac. What is it then? Then it is a pseudo GSAC. Pseudo gestational sac. Pseudo gestational sac is a marker of ectopic pregnancy. Marker of ectopic pregnancy. Because ectopic mein implantation has happened somewhere else. Yeah, let's say fallopian tube. So there will be nothing called decidua vasalis and decidua capsularis inside uterus. So pseudogestational sac is nothing but a decidua parietalis sac. Yeah, it is a DP, decidua parietalis, because vasalis and capsularis cannot happen in ectopic inside uterus. So are you understanding? It is a pseudogestational sac which is decidua parietalis sac. It is central in location. Yeah, it is central in location. On the other hand, the true gestational sac, I hope you remember the diagram which I have drawn. ऐसा करके जो diagram बनाया मैंने, इसमें true gestational sac is always eccentrically placed. You saw that ring inside the ring. Yeah, pseudo G-sac is always central. True G-sac is always eccentrical. Pseudo G-sac is always eccentrical. Sorry, true G-sac is always eccentrical. Pseudo G-sac is always central. Now suppose a patient passes this outside the uterus. Patient passes this outside the uterus. She will say, doctor, I have passed some fleshy mass. How will you know that this fleshy mass is a true G-sac or a pseudo G-sac? whether this is a deciduoparietalis or actually she was having intrauterine pregnancy. Provided she has no USG, there's a problem. Yeah, there's no USG. There's a problem. I don't know whether this mass which is passed by her is a pseudo G-sac or a true G-sac. Remember this thing. Villi will be absent in a pseudo G-sac and villi will be present in a true G-sac. Yeah, there will be villi. Obviously, chorion frondosum. Yeah, chorion frondosum will be present. Obviously, it will be present in a true G-sac because it is implantation. It's a blastocyst. It has trophoblast and trophoblast will form chorion frondosum. Yeah, जिससे प्लेसेंटा बनता है chorion frondosum वो रहेगा, but इसमें villi नहीं रहेगा. Villi will be absent in a pseudo G-sac. Am I clear about this, guys and girls? अब एक ऐसी लाइन जो एक्चुअली controversial है. There is one line which is controversial and that is critical cutoff to visualize gestational sac inside uterus. Critical cutoff to visualize gestational sac inside uterus. Asha is asking, sir, ectopic doesn't have deciduo capsularis also, as many times fetus is also present in ectopic pregnancy. Asha, my simple question to you is deciduo capsularis in ectopic pregnancy present inside uterus? No, na? I will redraw the diagram, Asha, for you. There is deciduo parietalis. I will write DP. And then I will also draw a fallopian tube where I will make a pregnancy over here. Yeah, implantation, Asha. So whenever implantation has happened inside uterus, there will be decidua basalis, there will be decidua capsularis inside uterus. If it is healthy intrauterine pregnancy, there will be decidua basalis, decidua capsularis inside uterus. There will be no decidua basalis, there will be no decidua capsularis if there is ectopic pregnancy, because that decidua basalis capsularis will happen only when there is intrauterine pregnancy. Now, this has happened inside the fallopian tube. What do you mean by decidua? Asha, what do you mean by decidua? Decidua is endometrium of pregnancy. How can implantation with outside the fallopian, outside the uterus give decidua basalis over there? Yeah. So in ectopic, there will be baby. Sometimes क्या बहुत बार तो हम लोग baby भी देखते हैं ऐसे, cardiac activity भी देखते हैं. Yeah, we see cardiac activity in ectopic. But then there will be no decidua basalis and capsularis inside uterus. That's my point. What did I say? If there is a gestational sac inside uterus with no yolk sac, then you should be suspicious of ectopic. Yeah. I repeat. If there is a gestational sac inside uterus with no yolk sac, we can wait and watch till 10 millimeter. And if 10 millimeters are crossed, that means there is a pseudo G-sac. It's not a true gestational sac. Had there been a true gestational sac, there would have been a yolk sac. Yeah, you should always think about ectopic pregnancy when you see a pseudo G-sac. Am I clear? Got it, Asha? I hope you got my point. If not, then ask me. Then I am telling you another statement altogether. Critical cutoff to visualize gestational sac in uterus. अब ये तो बात है gestational sac देखने की. Gestational sac नहीं दिखता तो क्या करते हैं हम लोग? Beta HCG वैल्यू करते हैं. 2000 is the critical cutoff for transvaginal sonography. Now many books have said many figures. Some books have written 3580 also. Williams ने भी बहुत equivocal, ambiguous statement दिया है. But remember, 2000 is the value which you should know regarding MCQs. This is the value which tells me whether this is intrauterine pregnancy or extrauterine pregnancy. What? Yes. This is also called a discriminatory zone. For a transvaginal sonography, this is called a discriminatory zone. Yeah, I will give you example. Let's say primigravida UPT positive. USG, no G-sac visible anywhere. Asha, listen carefully. There is no G-sac visible anywhere. Primary UPT positive, USG shows no G-sac visible anywhere. And beta HCG is 2000 international unit and rising. So my simple question to you is that, is this a live pregnancy? Yes or no? Alive pregnancy, yes, or alive pregnancy, no? Of course, alive pregnancy. Yeah. This USG is transvaginal sonography, and you know the critical cutoff is 2000. By 2000, you should see a gestational sac. You should see a gestational sac inside uterus. If you're not seeing gestational sac inside uterus, then it is called as pregnancy of unknown location. Pregnancy of unknown location, PUL. In fact, if you read any standard textbook, you will find that there are typical cases of A, single healthy intrauterine pregnancy, B, single unhealthy non-viable intrauterine pregnancy, C, pregnancy of unknown location, D, suspected ectopic, E, confirmed ectopic. Yeah, pregnancy of unknown location. You are not finding where it is, but it is there. Yeah, you do not know whether it is in the fallopian tube, in ovary, but I can assure you it is not there in uterus. Why? Had it been in uterus, by 2000 it would have been seen. Am I clear about this? This is pregnancy of unknown location, right? We give methotrexate in these cases. Pregnancy of unknown location, methotrexate therapy is to be given. How to give, everything will be covered in the topic called ectopic. I'll talk about it. In fact, an idea is already there with you. You have heard our lectures. Yeah. So yes, we'll talk about that as well. Okay. चलो, बहुत ज़्यादा चीजें बता दी इसके बारे में. But USG is one important thing which is oftenly asked in your exam. Yeah, you should know. Okay. All right. Next question. 42-year-old woman with previous history of having baby with Down syndrome is now 16-week pregnant. Which of the following would you suggest to her? Come on, tell me. She has history of Down's baby in past pregnancy. She is now 16-week pregnant. That means second trimester. Think, what should I advise to her? Should I advise amniocentesis? Should I advise obstetric ultrasound? Should I advise CVS? Should I advise fetal sampling? Or E, should I advise NIPT? Non-invasive prenatal testing. If I put that as well, non-invasive prenatal testing, what do you think is the right answer? Come on, tell me. The correct answer is amniocentesis. Yeah, it will be invasive procedure. Yes, there will be a risk of abortion. There will be risk of abortion, 0.3% risk of abortion is there. But since this patient has history of Down syndrome in baby, then you are supposed to do it because it is 1/100 risk already with history of Down syndrome. History of Down syndrome, 1/100 risk is there. And believe me, there is something called translocation 2121. What? Translocation 2121. There is 100% risk. 100% risk of Down syndrome again and again and again and again. So we do this test called translocation, detailed karyotype and genetic assessment, if there is recurrent pregnancy loss. If there is recurrent pregnancy loss. This test is done in mother or father of abortus. Yeah, that means couple karyotype is necessary if there is recurrent pregnancy loss. Okay. because there is translocation 21-21. Every baby would be Down syndrome baby and there may be recurrent pregnancy loss. Okay. Am I clear about this? Only one baby with Down syndrome. She has 1 by 100 risk of Down syndrome. We are not going to do this for the couple, but we are going to do amniocentesis of the baby. Yeah. Had it been a 11 week, 6 days pregnancy or 12-week pregnancy or a 13-week pregnancy, then you will have to do Corion-Willer sampling, CVS. So correct answer is amniocentesis. Corion-Willer sampling would be for a first trimester. Yeah. Fetal blood sampling is not done because we can do amnio and Corion-Willer samplings which are comparatively safer than choroidocentesis. NIPT is a screening test. It's not a confirmatory test. Yeah. NIPT is a screening test. It's not a confirmatory test. Here we want a confirmation, not a screening test. Yeah. She has Down syndrome baby. If you get a funny question that 42-year-old woman has come with para 2 living 2 previous normal delivery, has come with anxiety because her friend has delivered a Down syndrome baby. Now she is 16-week pregnant. This patient does not have her own Down syndrome baby. She is worried because her friend delivered a Down syndrome baby, that she is worried that her baby might also be a Down syndrome baby. Right now she is 16-week pregnant. What will be the right answer for such patient? For such patient we will do a screening test, a quadruple marker test. In India we do quadruple marker test in second trimester. A first trimester, then we do combined screening of first trimester. Yeah, we have questions on those things as well. Right now, correct answer in this case is amniocentesis. Okay. Next question. This is about early pregnancy hormone called HCG. So, human chorionic gonadotropin is a hormone formed at the time of implantation. Which of the following is incorrect about HCG? Incorrect about HCG. Radhika Bhardwaj has written E, NIPT. So out of these 5 options, obviously E would be the right answer, but believe me Radhika, NIPT is a secondary screening tool. Yeah, better answer would be quadruple marker test in India. Let me put my neck out and tell you, quadruple marker test is what we do in a patient who has no high risk. Yeah, she is for a screening, universal screening method. We do quadruple for a second trimester and combine for a first trimester. Yeah. NIPT is much better, but it's very costly, Radhika. Very costly. That's why it is a secondary screening tool. Yeah. When quadruple comes positive, then patient should be advised amniocentesis. But if she denies, then we do NIPT. Okay. Yeah. I hope you people must have advised a quadruple marker test in second trimester to all patients. Are you advising NIPT? Is it happening in your hospitals? Or are you advising NIPT to all pregnant females? No, na Radhika. We are doing only in a patient whose quad or combined has come positive and she denies a confirmatory test. Then we do NIPT. Yeah. Am I clear? Yeah. Next question is about HCG. It is highly raised in trisomy 21. It is maximum at 10 weeks. HCG takes more time to disappear from serum after abortion than after normal delivery. HCG is very high in placental site trophoblastic tumor, PSTT. In fact, syncytial trophoblast. Are you able to hear me now? All good? Yeah. So I was talking about the HCG hormone and I told you PSTT is a condition, placental site trophoblastic tumor. It's a gestational trophoblastic neoplasia where syncytial trophoblasts are absent. That's why HCG is very low. Yeah? HCG is very low. Yeah, can you hear me now? Aprajita, Asha, Radhika, Manas, I hope you are able to hear me now. Yes, I said placental site trophoblastic tumor is a condition where syncytial trophoblasts are absent. HCG is very low. Yeah, it is 1% of all GTNs. And since HCG is very low, tumor marker is, yes, anyone? What is the tumor marker of placental site trophoblastic tumor? Placental side trophoblastic tumor marker is HPL, human placental lactogen. Yeah, listen carefully. I am taking this fifth question. Human chorionic gonadotropin. And then what is incorrect about HCG? It is raised in trisomy 21. Everyone knows Down syndrome is having very high HCG. Agreed? And it is maximum at 10 weeks. HCG graph is typically rising and peaking at 10th week. That's why you people know, vomitings are very common in first trimester. HCG is highest in 10 weeks. It falls down after 10th and then constant after 16th. Yeah, constant after 16th week. Then I said it takes long time to disappear from serum after abortion. Obviously, when there is abortion, HCG is higher than a full-term delivery. Yeah, that's why it will take longer time. But placental side trophoblastic tumor will not have HCG as a tumor marker. Tumor marker is HPL and placental alkaline phosphatase. These are the two tumor markers of placental side trophoblastic tumor. Yeah, PSTT. Yeah, got it? Very clear. Few more factual things about HCG. Few more factual things about HCG. Now, HCG is produced from syncytial trophoblast. You have written that it is a glycoprotein with two chains, alpha and beta. Yeah, alpha is non-specific, beta is specific. Yeah, then half-life is 36 hours. Doubling time, if you get a blanket question, doubling time, the answer is 48 hours. Doubling time, 48 hours. As I told you, maximum at 10 weeks. Yeah. When I'm writing doubling time 48 hours, that means 100% increase would be there. But I have already told you plus or, if it rises by 55% or more, it is again considered normal. Yeah, doesn't have to be 100% every time. Even 55% increment is considered as normal. What if there is less than 55% increment? There is increment, but less than 55% increment in 2 days, it's a marker of ectopic pregnancy. It's a marker of ectopic pregnancy. Then what if it falls? HCG starts falling. Then it is abortion or a non-viable pregnancy. Yeah, HCG has fallen. These all things are for early pregnancy. Yeah, mark my words. Whatever you are doing about HCG is in early pregnancy. You will never do HCG in third trimester. Yeah. Second trimester, there is a quadruple marker test where there is HCG element. We'll talk about it later on. Right now you have written about HCG as falling in abortions, right? After you have written this, then HCG high conditions would be, yes, high HCG would be molar, multifetal, Downs, RH incompatibility, RH incompatibility and even chronic renal failure. Yeah, chronic renal failure. These are high HCG conditions. Then there are low HCG conditions. See guys, let me tell you, these are those lines which you learnt in your PG entrance days actually. But then in residency, these lines were not very useful and important, right? These lines are again important for you in NEET SS, yeah, regarding HCG. One question is generally asked about HCG somehow, yeah. So yes, low HCG conditions would be abortions, ectopics, and Edwards syndrome. Abortions, ectopic, Edwards syndrome. Yeah, high HCG, low HCG conditions in front of you. Okay. So yes, this is all about HCG. Let us talk about another question. Next question. 23-year-old Primi Gravida gives history of 5 months of amenorrhea and bleeding since 3 days, on and off. She has history of passage of mass in the morning along with some grape-like vesicles. On examination, there is bleeding present and os is open. Uterus is 14 week size. What is not correct in this treatment? This is the mass which she passed. Yeah? Guys, this is the mass which she passed. Grape-like vesicles as well. What's your diagnosis? Obviously, इससे easy diagnosis किसी का नहीं हो सकता. Yes, tell me. Spot diagnosis. ये क्वेश्चन ही दिया गया है तो उसके साथ भी डायग्नोसिस कर सकते हो, बट देन आई वुड हैव टू शो यू द पिक्चर बिकॉज मास कुड बी एनीथिंग ना. देयर कुड बी अ कंप्लीट मोल, बट दिस इज नॉट अ कंप्लीट मोल. दिस मास इज fetus and there are grape like vesicles. On examination there is bleeding present and os is open. Yeah, uterus is 14 week size. What is not correct in this treatment? What should you do in this case? Yeah, this is a partial mole. Correct. Partial mole requires suction and evacuation if it is closed os. Yeah, if a patient has passed the mass, we will do curettage. Yeah, we will not suck out because the os is open, vacuum will not be created. We will do curettage. The uterine curette, Blake's uterine curette will be used to curate the walls. And yes, partial mole pregnancy is to be curated out, removed out by suction evacuation if the os is closed, or by curettage if os is open, mass is passed. So yes, we will do curettage. Now partial mole is a molar pregnancy. Mole pregnancy can undergo malignant transformation. Malignant transformation is possible. In a partial mole, the malignant transformation risk is 2 to 5% risk. In a complete mole, there is 15 to 20% risk of malignant transformation. That is why you are supposed to do HCG monitoring. Correct, that is done. Methotrexate therapy, if HCG starts rising again. So HCG started falling down, but it started rising again. So it has to be GTN. Yeah. So we have to give treatment for GTN, and that would be methotrexate therapy. Histopathological examination of products of conception. This histopathology is considered as gold standard for any surgical disease. Yeah, we will do that. But copper T insertion for avoiding pregnancy for at least 6 months? No, we do not put copper T. Copper T is contraindicated in molar pregnancy, may it be partial or complete. But low dose OC pills are must. Yeah, copper T is not put because of 2 reasons. Copper T itself can cause bleeding, and we will get confused whether there is GTN formation or not. Secondly, copper T may cause perforation in the soft uterus. Yeah. So partial mole or complete mole, never put copper T. Okay, got it? Now few more factual things about partial mole. Now in partial mole, first thing first, it is due to multiple sperm entry. Yeah, it is due to multiple sperm entry. So 23X is already there and 2 more sets are there. So it is triploid or above. Yeah, more paternal chromosomes are there. It is called a dispermy plus diandry. 2 sperms will enter inside and there will be diandry. There will be 1 set of maternal chromosomes. Fetus would be there. Fetus would be there but congenitally malformed. Asha, which one is common? Complete mole or partial mole? The correct answer is complete mole. Yeah, 80% are complete mole, 20% are partial mole. Believe me, complete moles are very common as compared to partial mole. Partial moles are rare. Fetus would be congenitally malformed. And do you know, Asha, this complete mole, partial mole pregnancy, molar pregnancy is associated with vitamin A deficiency. Yeah, and Asian countries have highest incidence. Asian countries have highest incidence. The country which has maximum incidence, anyone? Country MCQ? Which country has maximum incidence of molar pregnancy? In fact, there every 30th or 20th pregnancy could be molar pregnancy. Yeah, ऐसी study थी. Very common condition called molar pregnancy in this country. The answer is Philippines. Manila, Philippines. Yeah, that country has highest incidence, followed by Taiwan. Yeah. Diandry. Radhika, dispermy, diandry plus, see, andry would be 2, na? But would be, देखो, there will be monogamy. Diandry plus monogamy, which will form a triploid. राधिका, नॉट जापान, जापान का नहीं है ये, फिलीपींस का है. या फिर ताइवान आता है. जापान के लिए कौन सा एमसीक्यू है? हमारा नहीं है, वो सर्जन लोगों का है. जापान के लिए गैस्ट्रिक कार्सिनोमास. या जापान इज नॉट द हाईएस्ट फॉर मोलर प्रेगनेंसी, दो जापान may have molar pregnancy, I don't deny that, but Japan may just gastric carcinomas are more, okay, and Philippines has highest amongst all the countries. Okay, that's what you should know. Okay, I'm not telling you Japan में नहीं होता है. Radhika, you are right, Japan में होता है, but not highest. Highest is in Taiwan, Philippines. Sorry, highest is in Philippines, then Taiwan. Okay, all right. Fetus is present but congenitally malformed. Uterus is less than period of gestation. There is one chemical immunohistochemistry marker called T57, which will be positive in partial mole. T57 is positive in partial mole. Then after writing this, then the USG will show fetus. USG will show placenta, but placenta shows focal hydropic changes. Placenta shows focal hydropic changes. Yeah. Okay. Then beta HCG is comparatively low. That is why hypertension, hyperemesis, hyperthyroidism, then theca lutein cysts would be rare. They are commoner in complete mole, they are rarer in partial mole. Okay. What should be the treatment of partial mole? This treatment is valid for even complete mole. The answer is suction and evacuation. You can use MVA syringe for that, manual vacuum aspiration syringe. Yeah. Followed by sharp curettage. Generally we don't do sharp curettage, right? In a pregnant patient we don't do sharp curettage, but here you are allowed to do. So sharp curettage, suction evacuation followed by sharp curettage. This is to be remembered, otherwise you will leave products of conception behind. So sharp curettage karke, we don't want to leave anything behind, that's why we are doing sharp curettage. Plus HCG monitoring. हम लोग पेशेंट के फाइल में ग्राफ चिपका देते थे, ग्राफ ऑफ HCG मॉनिटरिंग. या एंड HCG मॉनिटरिंग करते समय हमें देखना पड़ता था वेदर HCG इज राइजिंग और फॉलिंग. या टिल 0 you have to monitor, till undetectable for 3 weeks. वीकली HCG मॉनिटरिंग करना है till undetectable for 3 weeks. हम लोग ये सब भूल जाते हैं. या in our OPD we tell the patient weekly test करके आओ, भले पैसा लगे आपको करना पड़ेगा. Yeah, or else you get it done from our hospital. Yeah, generally they stay far away and they get it done from there only and they come. Weekly HCG monitoring till undetectable for 3 weeks. Then monthly HCG monitoring for 6 months. And in these 6 months, she should not become pregnant again. Low dose OC pills are to be given. Okay. If she is 40 plus, family complete, we should do hysterectomy. 40 plus, family complete, hysterectomy plus HCG monitoring. We should do HCG monitoring for sure. Asha has written oxytocin to be started before starting suction, or it has to be started once suction and evacuation has been completed. Asha, believe me one thing, that if you start oxytocin, there are studies which say that if you start oxytocin before the os is dilated, then molar embolus chances increase slightly. यहाँ पे क्या था, पेशेंट है ऑलरेडी पास द प्रोडक्ट्स ना, पेशेंट ने तो प्रोडक्ट्स पास कर लिए थे, then you can very well start, no problem about it. Oxytocin will help. जो लोग बोलते हैं ना oxytocin contraindicated, they should read the literature. Yeah, oxytocin is not contraindicated. Okay, so oxytocin is not contraindicated. Got it, guys? Got it? Very clear? Okay, but it should be started only after dilatation has started. Yeah. Bhupali has written sharp curettage increases the risk of injury. Yes, that's true. But I am quoting you textbooks which definitely say that sharp curettage for complete removal of the products of conception. You must be knowing, yeah, you people have seen it all. Misoprostol डालने के बाद कितने दिनों तक वो products निकलते रहते if you are left behind something. And assurance नहीं मिलता misoprostol से that you have completed the products, removal is complete or not. Sharp curettage से वो जो सब grating sensation, gripping sensation, bubbles at the os, और क्या, no bleeding, no products of conception, ये सब signs of completion आते हैं ना, grating, gripping, bubbles, no blood, no POCs, ये बहुत important है. Yeah, you should not leave anything behind. Am I clear about this, guys, girls? So yes, oxytocin can be given, but only after the dilatation has started. Secondly, sharp curettage is to be done to remove everything. Don't leave anything behind. Yeah, got it? Yeah. So after you have written this, done that, let us now talk about another question. Yes, there will be a question on complete mole as well. We will talk about the MCQs about complete mole as well. Let's take another question first. 23-year-old primigravida has 16 weeks of gestation. Her USG was done for the first time, which revealed the following picture. What is true regarding this case? What is this picture? Come on. Chapter वही चल रहा है, topic वही है. So you know this picture, right? Nobody will be there who will not know this picture. There will be multiple small, tiny, fluid-filled, hypoechoic spaces inside uterus. What is this picture of? This is a picture of complete mole. Correct? This is a picture of complete mole. Yes, complete hydatiform mole, molar pregnancy, vesicular mole, yeah, C mole, CHM. This is called as snowstorm appearance. ये कितनी बार क्वेश्चन आ चुका है, snowstorm appearance. You should know this. Yeah, complete molar pregnancy, vesicular mole, snowstorm appearance. Now, guys, girls, she would require suction and evacuation followed by HCG monitoring. Correct. She would require laparoscopic salpingostomy. No, this is not ectopic pregnancy. She would require methotrexate therapy and HCG monitoring. No, because this is not a GTN. GTN requires MTX plus monitoring. Complete mole is a benign disease. Complete mole is a benign disease, right? Only when we see the rise in HCG levels, then complete mole is said as invasive mole or choriocarcinoma, then we start methotrexate in that. Yeah, so she won't require methotrexate therapy. This blighted ovum which requires PG1 tablet, no. So correct answer has to be question number 7 का होना चाहिए A. She would require suction and evacuation followed by HCG monitoring. Yeah, agreed? Chalo, let me talk facts about complete molar pregnancy which are MCQ wise important to you all. Now complete molar pregnancy. complete mode pregnancy is due to empty egg fertilization. Empty egg fertilization. So there are no maternal chromosomes. So there is monospermy, diandry. The resultant product will always be diploid. It is always diploid. Most commonly it is 46XX. Very rarely, means 90% are 46XX, 90+% are 46XX. 5 to 10%, remaining 5 to 10% would be 46XY. 46XY. This is due to dispermy diandry. In an empty egg. The egg was not empty in partial mode, the egg is empty in complete mode. Yeah, dispermy diandry in an empty egg. Yeah, this is the result called diploid, but all paternal chromosomes, no maternal chromosomes at all. And since there are no maternal chromosomes, there will be no fetus. Only trophoblast in a grape-like vesicle. Only trophoblasts in grape-like vesicles would be there, right? T57 is negative. Uterus is more than period of gestation in 50% cases. What? Uterus is more than period of gestation in 50% cases. Uterus is equal to period of gestation in 30% cases. Uterus may be less than period of gestation in 20% cases, but for you people, remember, if a blanket question is there, uterus is more than period of gestation, exactly opposite to partial mole where uterus was less than period of gestation. Yeah, beta HCG is more than 1 lakh. There is diffuse hydropic, there are diffuse hydropic changes. Diffuse hydropic changes. Yeah, most common symptom, bleeding. Most specific symptom would be passage of grape like vesicles. Passage of grape like vesicles would be most specific symptom. This was not seen in an abortion, it was not seen in ectopic, it will be seen in molar. Yeah. Then hyperemesis, hyperthyroidism, then hypertension, preeclampsia, okay. Hypertension, they are very common, even theca lutein cysts. These all things are common. Yeah, very common. Okay. Hyperemesis, hyperthyroidism, hypertension, theca lutein cysts are common. Now, never ever remove the theca lutein cysts. These are functional cysts. Yeah, these are functional cysts. They are HCG based cysts. Right? We all know this. Treatment, same as partial mole. Treatment, same as partial mole. Okay, got it? Very clear? So same, ditto, same protocol. Remember, theca lutein cysts are never excised. Okay, theca lutein cysts are never excised. Even in torsion, they are not removed. Yeah. Even in torsion, you never remove ovaries. Yeah, if there is no torsion, you leave them behind. Right? Theca lutein cysts are never excised. These are functional cysts. We don't have to do cystectomy. If there is a torsion, save the ovaries, you remove the cysts. Don't remove the ovaries, these are young patients. Okay, I repeat. Theca lutein cysts are never excised. Even in torsion, they are, ovaries are left. Yeah, ovaries are saved. I should write it in a different way. Let me put it in a different way. Theca lutein cysts are never excised. If there is torsion, then remove the cyst, save the ovaries. If torsion is present, you do untorsion, never remove ovaries. Yeah, never remove the ovaries. Am I clear about this? You may do cystectomy, but never remove the ovaries. Got it? Very clear? Chalo. After writing this, didn't I tell you that you have to give a graph to the patient? And that graph should show that the HCG should fall, and once it falls to undetectable for 3 weeks, then you can do it monthly for 6 months. Yeah? Got it? Chalo. Next question. Now this is about abortions. 32-year-old, Gravida phi, para, 0, 0, 4, 0. This is TPAL formula. What is this formula telling you? She is G5 A4 patient. Gravida phi abortion 4 patient. Has 14-week pregnancy. She has 2 centimeter size intramural fibroid. 2 centimeter size intramural fibroid. Her torch titer shows IgG toxoplasmosis positive. Her cervical length is 3.5 centimeter. APTT is 120 seconds to the control of 40 seconds. She would require, come on, tell me. She would require what? Does anyone know about this question? Yes, anyone? She would require which management? Should I give aspirin only? Or should I give aspirin plus heparin? Should I give aspirin, heparin, spiramycin? Or should I do myomectomy, then aspirin plus heparin? What is your take on this question? Asha is writing aspirin. Okay. Can you diagnose what could be the probable cause of this condition? Though it requires a testing, but this is probably which syndrome? Yes, which syndrome it is? It is Apla syndrome. I'll talk about Apla syndrome for sure, but this is Apla syndrome with recurrent pregnancy losses. The correct answer has to be aspirin plus heparin. Aspirin plus heparin. Apla syndrome plus recurrent pregnancy losses, you are supposed to give aspirin plus heparin throughout pregnancy. Yeah, this is Apla syndrome, aspirin plus heparin. What about intramural fibroid? Does removal of intramural fibroid improve the outcome of recurrent pregnancy loss? No. Had it been FIGO type 0 or FIGO type 1, then myomectomy called hysteroscopic myomectomy. Had it been FIGO type 2 or FIGO type 2 to 5, then laparoscopic myomectomy. But myomectomy would have been the answer for any fibroid distorting the uterine cavity. Intramural does not distort the cavity. So there is no need of myomectomy for sure. Cervical length is great, 3.5, nothing to worry about. Toxoplasmosis से कोई फर्क नहीं पड़ता है. Remember, torch titers are useless investigation in recurrent pregnancy losses. Torch titers तो करते ही नहीं हम लोग. या एक बार पेशेंट अगर टॉक्सो से अबॉर्ट करती है तो नेक्स्ट टाइम शी विल बी इम्यून टू टॉक्सो. She will never have toxo abortion again. Yeah. So we will not do myomectomy. We will not give spiramycin. She is not a candidate for spiramycin. In fact, spiramycin की कोई जरूरत नहीं रहती है. Yeah. In recurrent pregnancy loss. Okay. Then because her this APTT test is a marker of which condition? Lupus anticoagulant. That would be there. APTT is abnormal in lupus anticoagulant condition. It's one of the Apla antibodies. Yeah. So if antibodies are there and she has recurrent pregnancy losses, then aspirin plus heparin. I'll teach you, I will tell you about APLA syndrome. Did you understand why not myomectomy and why not sphyromycin? Now I will teach you about APLA. APLA is basically having lab criteria, clinical criteria. Lab and clinical. Lab में there is lupus anticoagulant, which is called LA. Yeah, APTT will be abnormal. Hello, no voice. Hello, can you hear me? Why not sphyromycin? Asha, I can hear myself. Please check your local setting. ईयरफोन में हो तो वायर निकल गई होगी. Okay. I hope everyone is able to hear me. All good? दोस्तों, lab criteria lupus anticoagulant. Then there is anti-cardiolipin antibody. ACLA, anti-cardiolipin antibody. And then there is anti-beta-2 glycoprotein 1 antibody. The rule is any one of these three, but twice. Anyone should be positive, but twice. Yeah? 12 week apart. Anyone but twice, 12 week apart. Clinical criteria mein there is A, vascular thrombosis. B, yes, B is 3 or more abortions. 3 or more abortions of less than 10 weeks. C, 1 or more abortion of 10 weeks or more. Or D, early onset preeclampsia or IUGR causing preterm delivery of less than 34 weeks. Early onset preeclampsia or IUGR causing preterm delivery of less than 34 weeks. So any one clinical, any one lab is equal to APLA syndrome. See the case of APLA syndrome if there is any one clinical plus any one lab. Yeah. Now guys and girls, if she has APLA antibodies, plus either recurrent pregnancy loss or vascular thrombosis, you should give both aspirin plus heparin. Earlier aspirin was 75-80 milligram per day. Now we say 150-160 milligram. I'm writing 160 milligram aspirin per day. Yeah. Heparin you can give LMWH, which will be better than unfractionated heparin. This should be given throughout pregnancy. Yeah. She has APLA antibodies plus RPL or vascular thrombosis. Recurrent pregnancy losses था ना पिछले केस में, तो दोनों देना पड़ेगा. Only APLA antibodies or APLA plus early onset ... that you have already written. Early onset preeclampsia or IUGR causing preterm birth of less than 34 weeks, then the answer would become as aspirin alone. Yeah, then aspirin alone. Yeah, got it? APLA antibodies or APLA with early onset ... aspirin alone. So does aspirin prevent preeclampsia? Yes, we do give aspirin in a high risk pregnancies like hypercoagulable condition to prevent preeclampsia. Yeah, this is the treatment for Apla syndrome. Okay, am I clear about this? Okay, let us take another question. Next question. A pregnant female presents with bleeding at 18 weeks of gestation. On examination, cervical os was closed, but there was no history of expulsion of fetal and fetal placental parts. USG shows cardiac activity and placenta is 6 cm away from internal os. With 2 cm size retroplacental clot. What is the most probable diagnosis? Wow. So there is a uterus, there is a placenta which is in the upper segment, and there is a retroplacental clot. Cervix is closed, है ना? लिखा हुआ है ना cervix closed? Yes, cervix is closed, os is closed. Yeah, baby is inside, placenta is inside, there is no history of expulsion of products of conception, and most important thing, 18-week pregnant. Not 38-week pregnant, 18-week. So what is your answer now? Is it placenta previa? No, it is not. Placenta in the lower segment in a 24-week plus pregnancy would be placenta previa. Yeah. The correct answer has to be threatened abortion. Is it abruptio placenta? No. Had it been more than 24 weeks, then it is antepartum hemorrhage. Antepartum hemorrhage. But it is 18 weeks. So I can't put it as abruptio placenta. Yeah. Abruptio is when she is more than 24 weeks. Okay. Here the correct answer is question 9B. Threatened abortion. Okay. Got it. From our side, we will tell her to take bed rest, progesterone support weekly, 17-hydroxy progesterone support weekly, and reassess. Yeah, that's what we can do. This is threatened abortion. Okay, got it? Very clear? You understood why it is not abruptio? Because it is early pregnancy. Early pregnancy में antepartum hemorrhage नहीं, hemorrhage in early pregnancy होता है. Okay, got it? Very clear? चलो. Next question. 23-year-old newly married nulliparous patient has not got her menses since 2-3 months. She has checked the UPD which showed faintly positive line. Okay, fair enough. Yeah, faintly positive line. Her relatives have brought her to emergency room with a history of syncopal attack since 3 hours. On examination, her pulse is 108. BP is 84/52. My God, this is shock. Yeah. Cervical motion tenderness, left fornicial fullness. So obviously this is ectopic pregnancy. Yeah. USG suggests of free fluid in peritoneum with moving internal echoes. So hemoperitoneum is there. Yeah, hemoperitoneum. What should be the best modality of management in this case? Come on guys, you have seen it all, you have done it all. What should be the treatment of choice? In fact, the only treatment for ruptured ectopic. This is a clear-cut case of ruptured ectopic because vitals are unstable and she has cervical motion tenderness, left fornicial fullness, she is pregnant, yeah, ruptured ectopic, and there is hemoperitoneum. So give crystalloids, yes. Blood grouping cross matching, yes. Exploratory laparotomy with salpingectomy, this is what you are supposed to do. Should I do laparoscopy? No. Unstable patient, you should do laparotomy. Stable patient, we can try laparoscopy, but stable is very rare with ruptured ectopic. I have seen many patients who are stable and they are diagnosed on sonography that there is free fluid and moving internal echoes. In such conditions in KEM Hospital, Mumbai, we used to put a needle in our receiving room only, in the posterior fornix, and aspirate, and the blood which used to come out, the rule was the blood should never clot. है ना? पता होगा तुम्हें, तुमने किया भी होगा. Speculum डाला, sponge holding forceps से cervix को ऊपर किया, and you put a needle and aspirate. If the blood clots, that means it is due to local injury by needle. Yeah. If the blood doesn't clot, then it is hemoperitoneum blood. Okay, so the correct answer is A. Do not do culdocentesis because culdocentesis is done if there is a patient who is stable and you are suspecting ruptured ectopic. Then you do it. If she has shock, there is no need of culdocentesis. Shock kabhi unruptured ectopic mein nahi hota. Yeah. So you have to do exploratory laparotomy and salpingectomy. Yeah. Am I clear about this? All good? Very simple question. Next question. 25-year-old female has invasive mole. It has invaded the outer half of myometrium. It has not gone beyond that. Her prognostic score is 3. She wants to conserve her fertility for future childbearing function. What is the best plan of action in this case? So 25-year invasive mole, prognostic score 3, no metastasis anywhere. No metastasis anywhere. What should be the plan of action for this low risk patient of GTN? She is low risk GTN. Had the score been 7 or more, then she would have been high risk GTN. This is low risk GTN. What should be the right answer? Yes, tell me. What should we advise her hysterectomy since invasive mole is a cancer? I agree invasive mole is a cancer, but it doesn't require hysterectomy in all cases. Give 4 doses of methotrexate therapy and advise her contraception for 1 year after HCG is undetectable. Give Imaco regime and advise her contraception for 1 year after HCG is undetectable. Or give methotrexate after hysterectomy. What's your right answer? I think everyone knows this. Yeah? The correct answer has to be single drug chemotherapy. Huh? High risk patient, Imaco therapy. High risk patient, Imaco therapy. Low risk patient, single drug chemotherapy. But since you are appearing for NEET SS, you should know what are the high risk factors and low risk factors which determine the score. Yeah? I would like you people to tell me whether lung metastasis is considered as good prognosis or bad prognosis. Lung metastasis, good or bad? I will write prognostic markers. Good, bad. Site of metastasis. Surprisingly, lungs should be good prognosis. Pelvis would be good prognosis. Bad would be brain, bone, liver, bone, liver, GI would be bad prognostic markers. Then beta HCG value less than 1000 would be good. More than 1 lakh would be extremely bad. Yeah. Then age of the patient less than 40 would be good. 40 or more would be bad. Earlier there was blood group also, but recently WHO has changed that. The blood group O or A was good prognosis. Blood group is removed from the latest prognostic table. Yeah. Then interval between pregnancy and cancer. Interval between pregnancy and cancer less than 4 months, good. More than 12 months would be bad. Yeah. Interval between pregnancy and cancer less than 4 months, good. More than 12 months, bad. Then size of mets, number of mets would be directly proportional to poor prognosis. More the size, more the number, poorer the outcome. Agreed? Then previous failed chemotherapy. Previous failed chemotherapy. If there is no such history, good. If there is such history, bad. And last but not the least, previous pregnancy type. Strangely, molar pregnancy would be a good prognosis and full-term delivery would be a bad prognosis because after molar pregnancy, we see invasive mole more commonly. Yeah, choriocarcinomas are rare, but they are there. After full-term delivery, choriocarcinomas are seen more commonly, and choriocarcinomas have poorer prognosis. So previous pregnancy type is also very important. Okay. So if I give you a case of 42-year-old para 2 living to previous normal delivery, and she has brain metastasis, beta HCG 5 lakh, yeah, brain metastasis, there are 2-3 metastasis, beta HCG 5 lakh, what else do you want? Yeah, she is a high risk patient, she should be given Imaco regime, yeah, etoposide, methotrexate, actinomycin D, cyclophosphamide and oncovin. So etopo, methotrexate, actinomycin D, cyclophosphamide and oncovin, also called as vincristine. Yeah, these are the things which you are supposed to know about patient with GTN. Yeah, so give 4 doses of methotrexate, that would be day 1, day 3, day 5, day 7. Methotrexate therapy, 1 mg per kg intramuscularly. And along with this alternative day, you will have to give folinic acid, 0.1 mg per kg intramuscularly. Folinic acid, 0.1 mg per kg intramuscularly. Yeah. So this is single dose therapy which is to be done. Okay. Got it? Very clear. And since family is not complete, we will save her uterus. If family is complete, we remove the uterus. May it be invasive mole, we remove the uterus. Now, one thing which is not covered by me is that the logic and principle of complete mole and partial mole that she should avoid pregnancy was 6 months is extended to 12 months for GTN. GTN, may she be low risk or high risk? Should avoid pregnancy for 1 year after HCG is undetectable. I repeat, GTN, may she be low risk or high risk? She should avoid pregnancy for 1 year because we are doing monthly HCG monitorings. Earlier, let me tell you, before 2018, low risk patient 1 year and high risk patient 2 years was the protocol. Now, low risk patient, high risk patient 1 year, 1 year. Okay. Next question. Now, this is about a complete mole. You will be able to answer, I am very sure. 33-year-old patient has undergone suction and evacuation for complete molar pregnancy. One of the following is not corresponding to development of choriocarcinoma in this case. Come on, tell me. Bluish green vaginal nodule, increase in HCG level after suction evacuation, biopsy suggestive of severe anaplasia, or presence of villous structure in biopsy. Come on, think. What should be the right answer? 12th question. Right answer should be, yes, the point is choriocarcinoma. Choriocarcinoma. Will there be bluish green vaginal nodule? Yes, it's called vaginal mets. It is specific for choriocarcinoma. Yeah. Increase in HCG levels after suction evacuation, I told you, it may rise again. Yeah. If it is rising again, it is GTN, which could be invasive mole or choriocarcinoma. Anaplasia is a property of choriocarcinoma. Anaplasia is a property of choriocarcinoma, but villous structure is always absent. No villi seen. Muscle necrosis would be present. Anaplasia would be present. Anaplasia would be present. Yeah. Most common site of metastasis first would be lungs and then would be vagina. Remember, cannonball metastasis or snowstorm metastasis may be seen in lungs. Yeah. Then choriocarcinoma has a poor prognosis. As compared to invasive mole, choriocarcinomas have poor prognosis. Yeah. Then it is most common GTN occurring after non-molar pregnancy. I repeat this line again. It is most common GTN occurring after non-molar pregnancy. Which is the most common GTN otherwise? Most common GTN, blanket question, invasive mole. Most common GTN is invasive mole. It occurs only after molar pregnancy. It cannot happen after the normal delivery. It occurs only after molar pregnancy. You can't have an invasive mole happening after a full-term delivery or an abortion or a preterm delivery. No. Invasive mole will occur only after molar pregnancy. Here remember, villi are present and muscle necrosis would be absent. Villi present, muscle necrosis absent in invasive mole. Uterus perforation is specific for invasive mole. Yaad rakhna, uterus may get perforated in invasive mole. Okay. So these are the things which you should know about a case of choriocarcinoma and invasive mole. Okay. Got it? Very clear, my dear friends. Shall we proceed? Any question till now? Anaplasia is a property of choriocarcinoma. It's not a property of invasive mole. Invasive mole, villus structure would be there. Anaplasia is not there. Choriocarcinoma is full of sheets of anaplastic cells. Yeah. Villus structure is a property of invasive mole, not choriocarcinoma. Next question. One of the following is not a bad prognostic marker of GTN. Just now we have covered this. Previous pregnancy, full-term delivery, very bad. Beta HCG more than 1 lakh, bad. Interval from previous pregnancy more than 12 months, bad. But lung metastasis would be good prognostic marker. Yeah. So the correct answer has to be C. Let me show you that WHO's table actually, which helps me in knowing whether this patient is falling under low risk or not. I have told you the summary of that table, by the way. Yeah. The high risks and the low risks are told by me. Yeah, here we go. Look at this. This is that table. I will do one thing. I will get out of this picture and look at this table. You people have given exam now. You people must be knowing this table. ये तो by heart किया होगा table, right? This is that prognostic table where you get the scores. As you saw, age देखा, previous pregnancy देखा, age less than 40 is good, more than 40 is bad. Molar pregnancy is good prognosis. Full-term delivery is a bad prognosis. Asha is asking, most common GTN after molar is choriocarcinoma? No. Asha, most common GTN occurring after molar pregnancy is invasive mole. Yeah. Choriocarcinoma is most common GTN occurring after non-molar pregnancy. Yeah. Then interval I said less than 4 months and more than 12 months. Beta HCG less than 1000 and more than 1 lakh. Come on. Then largest tumor, as I told you, bigger the tumor size, poorer the outcome, right? Site of metastasis, lung falls under good prognosis. Number of metastasis, more the number of metastasis, poor the outcome. Previous failed chemotherapy, I told you, single drug, combination drug, failed chemotherapy is there, then bad prognosis. Otherwise good. Yeah. Got it? Very clear? So yes, this table, dekho na sir, 7 or more, madam, 7 or more is high risk patient. So for you people, you don't have to remember the whole table. Even if there is one component of high risk, na, let's say interval is more or beta HCG is more or metastases are there, then you consider this as high risk. That's my advice to you and give EMACO. Yeah. If she is a 25-year-old, molar pregnancy, yeah, no metastasis anywhere, then she will be falling under low risk. Okay. Got it? Very clear. Chalo. After writing about the GTNs and the molars, let us jump on to the next question. This is about cervical incompetence. The length of cervix for diagnosing cervical incompetence is less than. Now, this is very simple question for a postgraduate person. Yeah, but then simpler questions are asked in your entrance exam as well. So, length of cervix for diagnosing cervical incompetence, the shortening of cervix. Shortening of cervix means less than how many centimeters? It would be less than 25 mm. That means 2.5 centimeter. Yeah, shortening of cervix. Now, if there is a patient with short cervix plus history of preterm labor and delivery in past, short cervix with history of preterm labor and delivery in past, you should give cerclage. Plus weekly weekly progesterone injections. Yeah, yes, correct answer is 25 millimeter. Short cervix with history of preterm labor, delivery in past, you should do cerclage operation plus weekly progesterone injection. Patient with isolated short cervix, matlab no other history, only weekly progesterones are needed. Weekly progesterone injections are needed. Patient with history of painless second trimester abortion, then directly cerclage plus progesterone injections. Yeah. Patient has history of painless T2 abortion. Painless T2 abortion would be cervical incompetence, na? So you'll have to do direct cerclage operation. Here, cervical length assessment by USG is not necessary. She has sufficient proof that she has cervical incompetence. She is telling you that she has painless second trimester abortion. That's a sufficient proof for doing cervical cerclage operation. We prefer McDonald surgery, yeah, than Shirodkar surgery. McDonald is best. It's a purse string suture. We all know. We must have done this. We have done this. You must have done this. I have to, in KEM hospital वो first year residents का काम होता था. Yeah, cerclage का operation first year residents करते थे. Yeah, new आते थे, बस stitch लेनी है, ले लो. We are there. Speculum पकड़ के हम लोग खड़े रहते थे. चल ले, देखते हैं. We'll do it. Yeah, my dear friends, McDonald surgery is to be done. History of painless abortion to cervical length assessment is also not necessary. One more thing. What is necessary then? For cerclage operation, what is necessary? Rule out two things. Infections. There should be no local infection. If there is local infection, treat the local infection. Yeah? Rule out infection. And rule out congenital anomalies. So early anomaly scan is to be done. क्या पता एनेंसेफेली निकल जाए, एनेंसेफेली के साथ cerclage कैसे करोगे? So you have to rule out anomalies and then you have to take cerclage. Am I clear about this? Any question? Yeah, so this is 25 millimeter, but these all things which are written by me over here are valid for a case of cerclage. There will be many more questions on cerclage. We'll talk about them. Let's take another question. Ideal time for doing cervical cerclage surgery is, come on guys, you have done it. You people have done it. Cervical cerclage operation. When is the ideal time? 8 to 10 weeks, 10 to 12 weeks, 12 to 14 weeks, 18 to 28 weeks. First and foremost, you should know cervical incompetence. never causes T1 abortion. Never. कभी नहीं हो सकता. Then, second point you should know, incompetence will always have lesser period of gestation with every pregnancy. So let's say it was 19 week, it will become 18 week, next time abortion would be 18 weeks, then 17 weeks and so on. Yeah? So the correct answer is 12 to 14 weeks. Yeah? 12 to 14 weeks because obviously first trimester end ho raha hai, right? You should take a cerclage. What if patient comes late? It can be taken latest by 24 weeks. It can be taken latest by 24 weeks. Cervical cerclage surgery latest by 24 weeks. McDonald's hai, Shirorkar's hai. But there are few surgeries called as emergency cerclage surgeries. You must have heard about these names called Espinosa Florence operation and दूसरा operation है Worms operation. Yeah, these are the emergency cerclage surgeries. Otherwise, we do McDonald's, Shirorkar's तो बहुत rare है, right? McDonald is the preferred treatment. Yeah. Now, understand this thing that abdominal cerclage is done in cases where cervical length is very small. This very small is not defined in textbooks, but it is written that if you cannot take a cerclage stitch, let's say किसी ने तो radical trachelectomy कर दिया है. Radical trachelectomy is done for CA cervix cases. You cut the cervix. It is quite possible that cervical length would not be there. Yeah. Then you will have to go for abdominal cerclage operation. Okay. Am I clear about this? Ideal time for doing cervical cerclage is 12 to 14 weeks. Okay. Okay. For cervical cerclage, what is the suture material and location of the stitch? We all know this suture material has to be a non-absorbable. We use Marceline tape. So Marceline tape is used, or you can use black silk, but it has to be non-absorbable. You can't use the chromic catgut. Fibrosis okay, बंद हो जाएगा. Yeah, and the site is obviously the site of problem, and the problem does not lie in external os. The problem lies in internal os. So it has to be non-absorbable suture material at internal os. 16C. When to remove the stitch? When are you supposed to remove the stitch? A. 37 weeks. B. TPROM. C. Infection. D. Preterm labor. I am not giving you option, I am telling you ये चारों करेक्ट है. या ये ऑप्शंस नहीं है, मैं बता रहा हूं कि ये चारों करेक्ट है. इन चारों केसेस में यू आर सपोज टू रिमूव द स्टिच. 37 वीक्स, PPROM, infection और preterm labor. या रेस्क्यू सर्कलाज, आई टोल्ड यू ना आशा that 24 weeks तक हम लोग करते हैं. Yeah, textbooks have said you can do cerclage operation till 24 weeks. Rescue cerclage, emergency cerclage. Foley's catheter डालो, inflate करो, membranes should be intact. Membranes ruptured है तो we cannot do rescue cerclage. It will be a case of inevitable abortion. Yeah, we can do it till 24 weeks. Yeah, got it? Very clear? All right. So rescue emergency cerclage और एनी सर्कलाज फॉर दैट मैटर 24 तक करते हैं हम लोग. 24 तक किया जाता है. पोलिस कैथेटर रेस्क्यू में डालते हैं, इन्फ्लेट करते हैं, मेम्ब्रेन्स ऑटोमेटिकली अंदर चली जाती है, एंड देन यू टेक द स्टिच, एंड वंस यू हैव टेकन द स्टिच एट द टाइम ऑफ क्लोजर just deflate the balloon and pull it off so that membranes don't come in your stitch. Yeah, Asha is asking for indication when cervix is dilated. Asha, I'll show you the picture. Where is it gone? Give me 1 second. Oh, 4. Should be there only. Give me 1 second, Baba. Here it is. Look at this, Asha. This is for you. What you're seeing on the slide is a fetal head written over here. है ना? टकला है यहाँ पे. Anterior wall of cervix. Okay. Posterior wall of cervix. Okay. And you can see external os written over here, internal os, but this part of the cervix is closed. This is a closed cervix. Yeah. Length of cervix written over here is 0.95 centimeter. Yeah, 0.95. Obviously, it's a shortening of cervix. What about the internal os? Obviously, there is a big opening in the internal os. Yeah, there is a funnel shaped opening. Yeah, there is a funneling and shortening. This is not only shortening, यहाँ पे funneling भी हो गया, internal os खुल चुका है, right? Now this patient's external os is closed, length is there. This patient would not require emergency cerclage. This patient would not be, Foley's balloon अंदर डाल के हम लोग इसका stitch नहीं लेने वाले हैं. We'll do McDonald सीधा साधा. McDonald cerclage. McDonald cerclage would be done in this case. Had the cervix been open, उसका pattern U pattern होगा. ये Y pattern है. अगर आशा, if you are able to understand, ये Y pattern है. Yeah, Y pattern में दरवाजा बंद है. बंद है तो McDonald's लो, but U pattern है. That means external os is also open, internal os is also open, and the membranes are herniating out. Then you will have to do emergency cerclage or rescue cerclage. The os is open, the membranes are herniating, so you will have to do rescue cerclage operation. Am I clear about this, Asha? So in this case, you are going to do McDonald, सीधा साधा McDonald करेंगे. But अगर दरवाजा खुल गया है, if the door is open, then emergency cerclage. Okay, got it? Very clear? I hope you understood. Okay. Next question. Okay, we have done implantation wala question, so it will be very easy. Implantation occurs in which stage of zygote? We have done the stage of implantation. I have drawn the diagram as well. Yeah, the stage is called as blastocyst. We have covered 8-cell stage is there in fallopian tube. Yeah, 16-cell enters uterus. Blastocyst is on day 5 and then implantation also. And embryonic plate is a double bleb sign. Yeah, we have done this already. No need to repeat it again and again. Let's jump to next question. Origin of amnion. When I said that there is inner cell mass, it forms embryonic disc. Asha is asking till how much cervical dilatation, sir? Asha, remember, we can do cerclage operation till less than 3 centimeter. I mean 3 or less than 3 centimeter. More than that, we can't do. The rule is membranes should be intact. Second rule is uterine contraction should be absent. Yeah. If there are uterine contractions, you cannot take a stitch. Yeah. So remember that 3 centimeter or below, you can take emergency cerclage. Okay. Got it? If it is more than 3, bringing the cervix close to each other becomes very difficult. Yeah. So yes, your question's answer is 3 centimeter. Okay. Now the question is about this same blastocyst which has formed embryonic disc. Now embryonic disc will have ectoderm and that ectoderm is going to continue in the amniotic sac side, and it will be called as amnion. Yeah, this is amnion containing amniotic cavity. So amnion is a continuation of ectoderm. Amnion is ectodermal in origin. Okay, got it? Very clear. What about endoderm? Endoderm lines the yolk sac cavity. That's why yolk sac is also called as endodermal sinus cavity. Yeah, so amnion is ectodermal of embryonic plate. Yeah, there is something called intraembryonic mesoderm also, and that mesoderm comes from primitive streak. It comes from primitive streak, and this mesoderm forms vessels and connective tissue. Mesoderm forms vessels and connective tissue. Ectoderm forms skin, hair, nails, optics. Skin, hair, nails, optics, central nervous system, peripheral nervous system, dentition, everything which is outside is ectodermal. Endoderm, on the other hand, yeah, this is endoderm, would form foregut, midgut and hindgut. So remember, yolk sac is covered by endoderm. Amniotic cavity is covered by ectoderm called amnion. Okay, am I clear? Placenta is made up of two things: decidua basalis and chorion frondosum. Yeah, decidua basalis and chorion frondosum. Chorion frondosum is nothing but tertiary villus structure. Chorion frondosum is tertiary villus structure. Tertiary villus is nothing but syncytiotrophoblast, cytotrophoblast, extra embryonic mesoderm plus fetal capillaries, fetal vessels. Tertiary villus structure would be syncytio, cyto, meso and fetal vessels. Yeah. So now you know everything about the early pregnancy ka origin. Okay. Let's talk about another question. The main source of amniotic fluid in first half of pregnancy. Yes, anyone? Main source of amniotic fluid in first half of pregnancy. ऐसा कोई क्वेश्चन आता है तो क्या लिखेंगे? लेटर हाफ आया तो क्या लिखेंगे? लेटर हाफ ऑफ प्रेगनेंसी में क्या लिखेंगे? अगर लेस देन 12 वीक्स आया तो क्या लिखेंगे? 12 to 20 वीक्स आया तो क्या लिखेंगे? बियॉन्ड 20 वीक्स यानी कि लेटर हाफ आया तो क्या लिखेंगे? द करेक्ट आंसर फॉर फर्स्ट हाफ ऑफ प्रेगनेंसी इज स्किन ऑफ द बेबी, fetal skin. And later half of pregnancy would be, yes, anyone? Yes, fetal urine. Yeah, later half fetal urine होता है. Okay, and then 12 to 20 weeks skin होता है, fetal skin. Less than 12 week तो maternal plasma रहता है, उसका transudation. So fetal skin is the right answer. 19 का क्वेश्चन का आंसर है C, right? Fetal urine is 20 weeks and beyond. Okay. Kidney would be the right answer for later half. That's what I'm teaching you. Kidney would be for later half of pregnancy. Remember, urine production begins at 12 weeks. Yeah, urine production begins 12 weeks, but it is predominant source of amniotic fluid. Yeah, in later half of pregnancy. उससे पहले स्किन होता है, because skin is not keratinized. keratinization of skin is at 22 to 25 weeks. Yeah, uske skin cannot become a major, skin cannot become a source of amniotic fluid. Yeah, the correct answer is fetal skin. Am I clear? Next question. We have covered this. Signs and symptoms of hydatidiform mole include the following except. I said most common symptom has to be vaginal bleeding called hemorrhage in early pregnancy. Uterus is more than period of gestation in 50% cases. Hypertension, preeclampsia is very common in complete mole. Yeah, H-mole, complete mole, preeclampsia is very common. In fact, it is the only condition where preeclampsia, eclampsia, gestational hypertension can happen even before 20 weeks. Yes, you heard it right. Preeclampsia, eclampsia, gestational hypertension are generally not seen before 20 weeks. But if you see them before 20 weeks, you are dealing with a complete molar pregnancy. So USG is showing snowstorm at 12 weeks of gestation and BP is 140/92 readings. Urine albumin 4+. This would not be called as chronic hypertension. This would be called as preeclampsia. Yeah, preeclampsia. There is proteinuria, there is hypertension. Even in early pregnancy, you will call it as preeclampsia only and only in this condition called molar pregnancy. But hypothyroidism is not seen. Yeah, it is actually hyperthyroidism because HCG has alpha chain and beta chain. You have written that alpha chain is same in TSH, LH and FSH. They have same alpha chain. HCG is very closely related to LH, but it has the function of TSH also. Yeah, you must be knowing that TSH levels are different in pregnancy, especially in first trimester. TSH levels fall. Yeah, 2.5 से नीचे रखना होता है हमें TSH. Yeah, remember TSH should be less than 2.5 in first trimester. Okay, क्योंकि HCG is high in first trimester. HCG has TSH like function. Okay, just because I am asking about thyroid, which is most common cause of hypothyroidism in pregnancy. Yes, anyone? Most common cause of hypothyroidism in pregnancy. The correct answer is Hashimoto. Remember, Hashimoto's disease. Most common cause of hyperthyroidism. Most common cause of hyperthyroidism in pregnancy. Yes, anyone? Most common cause of hyperthyroidism. थायराइड का टॉपिक नहीं पढ़ा होगा, मेडिकल डिसऑर्डर्स में आता है, वेरी इंपॉर्टेंट टॉपिक, थायराइड टॉपिक. This is not related to early pregnancy. I am just covering because I am talking about hypothyroidism, hyperthyroidism. Which is most common cause of hyperthyroidism? Come on. The answer is Graves' disease. No, it is not iodine deficiency. Most common cause of hypothyroidism is Hashimoto's. Yeah? आपके आजकल सबके नमक में आयोडीन है. Yeah? पहाड़ों में रहने वाले लोगों के भी नमक में आयोडीन है. Yeah? Hypothyroidism, iodine deficiency is not a thing presently. Hashimoto is the thing most common. Yeah, I'm not denying that iodine deficiency is still there, or iodine, is supplemented to pregnant females as well. Yeah, but then understand this thing. It will be only through diet and salts. The correct answer is Graves' disease for hyperthyroidism and Hashimoto's for hypothyroidism. Yeah. Guys and girls, Graves' disease में TSH receptor antibodies रहते हैं. TSH receptor antibodies. No, Aisha, don't say sorry. These are the things which are obviously written in standard textbooks. So I'm quoting you the standard textbook size. So Graves' disease, there are TSH receptor antibodies. My question to you is, which of the two, hypothyroidism, hyperthyroidism, which of the two can cause IUGR? Which of the two would guys cause IUGR? Hypo or hyper or both? The correct answer is hyperthyroidism. Yeah? Hypothyroidism does not cause IUGR. Hypothyroidism only causes abortions. Hyper also causes abortions. But hyperthyroidism also causes IUGRs. Okay? Got it? Then, if patient is already a hypothyroid patient, always increase her thyroid supplement by 30 to 50%. If she is taking 100 microgram, make it 125 to 150 microgram. Yeah. For hyperthyroidism, if she is on marcazoles, please shift the marcazoles to a safer drug. Propylthiouracil is safe in pregnancy, especially in first trimester. Propylthiouracil. Okay, got it? If there is a thyroid storm which is seen in hydatidiform mole, what's the treatment? Treatment of thyroid storm, especially seen in a molar pregnancy. Then the answer would be, yes, anyone? What's the answer for thyroid storm? Propranolol plus sometimes iodine plus steroids. And obviously for hyperthyroidism, we have to treat the cause. Yeah, propylthiouracil would be anti-thyroid drug. Okay, got it? These thyroid stimulating hormone receptor antibodies can pass also. Yeah, baby may also suffer from thyroid dysfunction because of maternal thyroid disorder. Yeah, got it? Very clear? So this is all about, yeah, for thyroid storm we give propranolol. Yes, beta blocker. Steroids are given because there are antibodies. Steroids will suppress. And iodine. Not radioactive iodine. No radioactive iodine to be given in pregnancy. No radioactive iodine. Next question. Very simple question actually. Now we have covered a complete mole wala question. True about complete mole. Fetal parts are present? No. Beta HCG doubles in 7 days. What do you say? Normal doubling time कितना होता है? 2 दिन का रहता है. इसमें तो 6 घंटे में डबल होता है. This is false. Normal uterine size, not in most of the cases. Not in most of the cases, so I'll put a cross. Preeclampsia can happen before 20 weeks. Yes, this is true. If there would have been C and D both, that is also possible. Normal uterine size is also possible, but in 30% cases. More than normal would be seen in 50% cases. So correct answer is D. Okay. Next question. Complete mole can convert into invasive mole. Okay, fine. It is indicated by all except. It is indicated by all except A, B, C or D. Now this is a tricky question. Let me guarantee you that you will give me a wrong answer. Complete mole can convert into invasive mole, that we know. It is indicated by all except. Come on, think and tell. A. Plateau HCG, enlarged uterus, persistent thecal lutein cyst or suburethral nodule. What is your right answer? Question number 22. Tell me, write 22A, 22B, 22C, 22D. Think and tell. The correct answer has to be. Give me 1 second. रोहित लेक्चर चालू है, मैं बोलता हूं. Yeah. The correct answer has to be. Let me surprise you. The correct answer is suburethral nodule. Yes, suburethral nodule is nothing but vaginal bluish green vaginal nodule. It is seen in vaginal mets. It is seen in choriocarcinoma. Sir, but what about plateau HCG? Is it seen? Yes, it is seen. Enlarged uterus? Yes. Persistent thecal lutein cyst? Yes. Let me tell you, there is something called as persistent GTD condition. Persistent GTD is a monitoring. इट्स अ मॉनिटरिंग डायग्नोसिस. मैंने बताया था ना, कंप्लीट मोल के बाद मुझे पेशेंट के फाइल में ग्राफ लगाना पड़ता है. आई हैव टू पुट अ ग्राफ इन द पेशेंट्स फाइल. मॉनिटरिंग डायग्नोसिस आफ्टर सक्शन एंड इवैक्यूएशन. या सक्शन इवैक्यूएशन का मॉनिटरिंग डायग्नोसिस. यस, राधिका इज राइट. दिव्यानी इज राइट. Suburethral nodule is the marker of choriocarcinoma, not invasive mole. Yeah. Persistent GDD, the monitoring diagnosis after suction evacuation. The criteria for diagnosis. Criteria for diagnosis would be A, HCG rises by 10%. HCG rises by 10% for how many weeks? 2 weeks. B, HCG plateaus for 3 weeks. Says there is no rise, there is no fall for 3 weeks. C, HCG present even after 6 months. And D, histopath suggestive of anaplasia. I told you anaplasia is the marker of choriocarcinoma. Any one of these 4 would be sufficient to call it as persistent GDD, and persistent GDD is the monitoring diagnosis. It is not a separate cancer. It can be either invasive mole or it can be choriocarcinoma. It can be either invasive mole or choriocarcinoma. Yeah, invasive mole की property perforation of uterus, choriocarcinoma की property suburethral nodule, bluish green vaginal nodule. Plateau तो दोनों में दिख सकता है, invasive में ज्यादा दिखता है, choriocarcinoma में HCG is very high. Yeah, but that is not a point. Point is suburethral nodule that is seen in choriocarcinoma. Am I clear about this? Yeah, tricky question. Next question. Most common cause of recurrent pregnancy loss. Acha, you people need a break. अच्छा, what we'll do is this question, एक question करते हैं and then we'll take a break. Most common cause of recurrent pregnancy loss. 50% cases are from those causes. And the correct answer is idiopathic. Recurrent pregnancy loss, that means 3 or more abortions in past or 2 or more confirmed abortions in past. Confirmed abortions would be either USG or histopath. Yeah. Idiopathics are seen in 50% cases. This is American Society of Reproductive Medicine definition. So most common cause has to be idiopathic. But if idiopathic is not there in option, then autoimmune would be there in 20% cases. And most common autoimmune would be Apla syndrome. Most common autoimmune would be Apla syndrome. There are others like SLE. Yeah, autoimmune SLE is also there. Third would be anatomical, where there is cervical incompetence as most common. Then submucous fibroid. Then Asherman syndrome. Then Mullerian anomalies, don't forget. जिसमें septate uterus is the most common Mullerian anomaly. Yeah, Mullerian anomalies. Then anatomical में there may be क्या हो गया, एक तो सर्वाइकल इनकॉम्पिटेंस लिखा, सबम्यूकस फाइब्रॉइड लिखा, एशरमैन लिखा, मुलेरियन, हाँ बस इतना ही. तो एनाटॉमिकल्स में इतने हैं. देन 4th नंबर आता है एंडोक्राइनल, अनकंट्रोल्ड डायबिटीज, थायराइड. या आई वुड नॉट राइट इन्फेक्शन, एक काम करता हूं इन्फेक्शन लिख के काट देता हूं. टॉर्च सिंड्रोम्स कैनॉट कॉज recurrent pregnancy losses, so it's useless to do it. Yeah, हाँ एक और cause है genetic. अभी अभी मैंने बताया था, couple karyotype is needed because of balanced translocations. There may be recurrent pregnancy loss. This is the rarest cause of them all. Yeah, rarest cause of recurrent pregnancy loss would be genetic. The correct answer has to be idiopathic. If idiopathic is not there an option, then autoimmune. But if the option list is like this, number 1, Apla syndrome, number 2, anatomical, then endocrinal, then genetic. अगर ऐसा कुछ सेट दिया है तो प्लीज डोंट पिक अप आपला, प्लीज पिक अप एनैट. एनैट इज मोर कॉमन देन आपला. है सर, अभी तो कहा ऑटोइम्यून इज मोस्ट कॉमन. आपला इज वन ऑफ द ऑटोइम्यून. एनाटॉमिकल इज अ ग्रुप, उसमें बहुत सारे कंडीशंस है. या इफ आपला दिया है तो आपला इज नॉट द ऑल ऑटोइम्यून. आपला इज वन ऑफ द ऑटोइम्यून, इनफैक्ट मोस्ट कॉमन ऑटोइम्यून. Anatomicals would be more common than individual Apla syndrome. Did you get this thing? Yeah, guys, girls. So that is all about it. So what we will do is, right now it's 7:20. We'll take a 10-minute break. Next session at 7:30 p.m. Yeah, next session 7:30 p.m. Come back soon. All right, guys, welcome back for the next session. And yes, we were talking about the recurrent pregnancy loss causes. I want you people to understand that if you get a question about singleton abortion, then things are totally different. For a singleton abortion, if you get a question, most common cause of abortion, plain simple vanilla question, most common cause of abortion, the answer has to be chromosomal abnormality. Believe me, chromosomal abnormalities are seen in 50% cases. Are you all back? I hope you are all back. Welcome back for the next session. Okay. Chromosomal abnormality. And in chromosomal abnormality, most common is trisomy. And in trisomy, most common would be 16, 13, 18, 21, yeah, etc. Most common cause of abortion पूछा जाए, and options are A, trisomy 16, B, trisomy 21, C, trisomy 18, or D, monosomy X. The correct answer will neither be trisomy 16, 21, 18. The correct answer will be monosomy X. Mark my words. Yeah, this is the right answer. Because monosomy is more common than individual trisomies. But if the options are A, trisomy, B, monosomy, C, triploidy, D, quadruploidy, then the correct answer has to be trisomy. Obviously, here trisomy is a bigger answer than monosomy because trisomy is a group which is bigger than monosomy. Yeah, here monosomy X is more common than individual trisomies. If you get a question like most common cause of abortion, A, trisomy, B, monosomy, C, aneuploidy, D, triploidy, the correct answer in this case would be, come on tell me, अगर वापस आ गए हो, चाय अपनी हो गई है आपकी, तो tell me, if you have had your tea, let me know what is the correct answer for this question. Most common cause of abortion, trisomy, monosomy, aneuploidy, triploidy, the correct answer has to be aneuploidy. Yeah, aneuploidy. Why? Because aneuploidy is anything which is non-46. 46 are euploids. Non-46 are aneuploids. Okay? Am I clear about this? देखो दोस्तों, chromosomal abnormality 50% cases में मिलती है, which simply means that 50% abortions are euploid abortions. 50% abortions are euploid abortions. Okay. Chromosomal abnormality 50%. Euploid abortions are 50%. So if you get a question in a distorted way, most common karyotype of abortus: A, euploid; B, trisomy; C, triploidy; or D, monosomy. Then what will be your right answer? Most common karyotype of abortus अगर पूछा जाए तो इस सेट में आंसर सही होगा euploid. 50% are euploids, 50% are aneuploids, and in aneuploids there are trisomies, monosomies, triploides, and so on. Yeah, the correct answer has to be euploid in this question. Okay, am I clear? So there should be no controversy regarding these questions because plain simple vanilla है ये, that chromosomal abnormalities के types क्या है, and 50% of the abortus would be euploid abortus. Okay, got it? Next question. Let's talk about next question. Most common cause of second trimester abortion. May it be second trimester, may it be first trimester. The correct answer is same, chromosomal abnormality. Remember this. Many people would pick up cervical incompetence. No, it is not the right answer. Even for second trimester abortion, it is chromosomal abnormality. Am I clear? The same set. But believe me, first trimester abortions are 90%, second trimester abortions are just 10%. Cervical incompetence rate is most common anatomical cause of T2 abortion. Yeah? The only Mullerian anomaly which can cause first trimester abortion would be, the only Mullerian anomaly for causing first trimester abortion would be septed uterus. Otherwise, Mullerian anomalies are associated with second trimester abortions. Cervical incompetence, second trimester. Mullerian anomalies, first and second trimester. Luteal phase defect, T1 abortion. Some people say it's a myth. Luteal phase defect does not exist. But then you should know that we always give progesterone support. So there has to be some element, na? So luteal phase defect causes first trimester abortion. The correct answer is chromosomal abnormality. Okay. Most common cause of second trimester is again chromosomal. Most common cause of first trimester is chromosomal, also for second trimester. Mark my words. Okay. Am I clear about this? Alright, next question. 23-year-old primigravida with abdominal pain, syncope and vaginal spotting. She has ectopic pregnancy. Least common site of rupture of ectopic. Yes, tell me. Least common site of rupture in ectopic. Is it ampulla? Is it isthmus? Is it fimbrial end? Is it intramural? You know that fallopian tube has 4 parts. There is a part inside. It's called as intramural. Then there is a straightened part called as isthmus. Then there is a distended part, the longest part called as ampulla. Then there are finger-like projections called as fimbrial end, also called as infundibulum. Infundibulum. Come on, tell me, which of these 4 sites would have least risk of ectopic rupture? Least risk of rupture in ectopic. Come on, tell me, guys. Yeah? By the way, ampulla is the longest and the widest part. It is most common site of ectopic. Ampulla is the most common site of ectopic because it is most common site of fertilization. Asha is writing as a D. That means intramural. I would say intramural is the least common site of tubal ectopic, but not for the rupture. No, Asha, this is not the right answer. The correct answer is, no, Radhika, this is not the correct answer. The correct answer is fimbrial end. Least common site of rupture. Rupture is least. I am not talking of least common site of ectopic. Least common site of ectopic is intramural. But the question asks is least common site of rupture of ectopic. Imagine, if there is ectopic over here in the fimbria, will it rupture the fimbria or will it fall in the abdominal cavity? The correct answer is it will fall in the abdominal cavity. This answer is valid even for ampulla. So I would write this clear line, most common outcome of ectopic is actually tubal abortion. Yeah, tubal abortion में there is no rupture. It's just that fallopian tube से वो fall हो जाता है abdomen में. Yeah, patient would be stable patient. Yeah, but this has fallen in the abdominal cavity. And least risk of rupture would be there in fimbrial end. 25C. Because most of the time it will fall in the abdominal cavity. Yeah, tubal abortion सबसे ज़्यादा fimbrial end में होगा. Regarding intramural, believe me, it is that ectopic which continues for longest time in tube. It can continue till 14 weeks to 18 weeks as well. Then it will rupture. हम लोग इसे cornual ectopic कहते हैं ना. Intramural is nothing but cornual ectopic. Cornual ectopic. Yes, absolutely. In fact, Asha, not only 12 weeks, I have had a patient of 16-week cornual ectopic. ऐसा यूट्रस था उसका. Cornual ectopic. It was 16 weeks. Yeah, it is the ectopic which runs the highest. I mean, it runs even till second trimester in some cases. And then it will rupture because it is covered by myometrium. Asha, you are right. It is covered by myometrium. Yeah. So understand, that would rupture for sure. Fimbrial ectopic would not rupture. It will fall in the abdominal cavity. Am I clear about this? Most common site would be ampulla. No doubt about it. Ampulla is the most common site of ectopic. Earliest site of rupture. Earliest site of rupture. It will rupture as early as 6 weeks. Would be isthmus. Earliest site of rupture would be isthmus. Okay, am I clear? So many controversial, non-controversial lines I have written, but believe me, these are all correct lines. Yeah, am I clear about this? Any doubt? Ask me. The correct answer has to be fimbrial end. Okay, next question. Ovarian ectopic pregnancy, very rare. In fact, most common extra tubal ectopic is ovarian ectopic. Is diagnosed by which criteria? Yes, this is informative question. You should know it. It is diagnosed by Spiegelberg's criteria. Spiegelberg criteria says that A, ectopic mass should be in ovarian fossa. B, ectopic mass should be covered by ovarian tissue. Ovarian tissue coverage होना चाहिए, walls पे ovarian tissue. Radhika, ampullary rupture happens at 8 to 10 weeks. Ampullary rupture is 8 to 10 weeks. 6 to 8 weeks would be isthmic rupture. Yeah, isthmus ruptures the earliest. Ampulla ruptures 8 to 10 weeks. If you want to select one, then 8 weeks. 6 for isthmus, 8 for ampulla. Then fimbrial end does not rupture, and intramural part can go till 12 weeks, sometimes 14 weeks, sometimes 16 weeks. It is running for the longest time. But fimbrial rupture does not happen commonly. Yeah, it's a very rare thing. Yeah, it falls in the abdominal cavity commonly. I am now teaching you Spiegelberg criteria. Ectopic should be in ovarian fossa, should be covered by ovarian tissue, should be connected to uterus by ovarian ligament. Asha is asking which is least common. Asha, when I told you that intramural is the least common tubal ectopic, it does not mean it is least common ectopic. Least common ectopic has to be caesarean scar ectopic. Second rank goes to abdominal ectopic. So caesarean scars are rarest. Caesarean scar ectopics are rarest. Yeah. Abdominal ectopic would be second rare. Right? D would be this ectopic mass. I said C would be ectopic mass connected to uterus by ovarian ligament, and D would be fallopian tube of same side should be intact. Fallopian tube of same side should be intact. So these are the 4 rules for Spiegelberg's criteria. Rubin's criteria, it's for cervical ectopic. Nowadays we use another criteria for cervical ectopic. It is called as Paman criteria. Paman. Yeah. Studiford criteria is for primary abdoectopic. Wrigley is a forceps. Wrigley's are forceps. उसका कुछ criteria से कोई connection नहीं है. Wrigley's have nothing to do with ectopic pregnancy. Okay. Am I clear about this? Guys and girls. आगे बढ़े. I have written Spiegelberg's criteria in front of you. Yeah, ectopic mass should be in ovarian fossa, should be covered by ovarian tissue, connected by ovarian ligament, and fallopian tube intact. No rupture of fallopian tube. Next question. Stage of gestational choriocarcinoma which is spread up to lungs and beta HCG is 58,000. Duration of disease 4 months. Come on, tell me fast. Which is the stage of choriocarcinoma? Is it 3A, 3B, 4A, 4B? Lung metastasis. Beta HCG 58,000. Duration of disease 4 months. So you should know staging very well in order to attempt this question. Otherwise, akkad, bakkad, bambe, bo, 80, 90, pure 100. Tick karo. Yeah? Then you have to do tukka. You have to know staging, and you have given exam, you should know the staging. Come on, tell me. What is the stage of this patient? Till the time you say the answer, tell the answer, I will write the staging. Stage 1 is uterus. Stage 2 is other genital organs. Stage 3 would be lungs. And stage 4 would be distant metastasis. Yes, you are right. Aprajita, Radhika, you are right. Distant mets should be stage 4. Then there is A, no risk factor. B, 1 risk factor. C, both risk factors present. Both may, there is beta HCG more than 1 lakh, IU per liter, and duration of disease more than 4 months. Sorry, more than 6 months. I am so sorry. Duration of disease more than 6 months. Beta HCG more than 1 lakh and duration of disease more than 6 months. Since it is lung metastasis, it has to be 3 and no risk factor present. So A. So question number 27, A is the right answer. Yeah? A is the right answer. Now, there are very few informations. There is very few information given in this question. They should have told much more things in order to know whether single dose should be given or combination chemotherapy should be given. Yeah. So yes, information given over here is less. We should know other factors and variables as well in order to decide the treatment. यहाँ पे सिर्फ staging के बारे में पूछा है. So the stage is 3A. Next question. We have covered this. We will not cover it again. Implantation days. Which day after fertilization? The answer is 6 to 7 days. of fertilization. Yeah, we have done that. Okay. Chadwick sign means, what is Chadwick sign? Chadwick sign, also called as Jacquemer sign, is bluish discoloration of vagina. Agreed ना? Bluish, ये तो सबको पता है, ये तो बच्चों को पता है. Bluish discoloration of vagina and vestibule is Jacquemer or Chadwick sign. It is seen from 8 weeks. What is lateral fornicial pulsation called as? Asha is asking, risk factors will be. Asha, I told you, no? Risk factors will be beta HCG more than 1 lakh. That's one risk factor. And duration of disease would be more than 6 months would be another risk factor. Yeah, in this case, duration of disease is 4 months, so that risk factor is not there. Beta HCG is less than 1 lakh, so that risk factor is not there. So it is A as the right answer. 3A. Blue. Achha, you are talking about next question. Okay. Bluish discoloration of vagina. Correct. That is called Chadwick sign. Lateral fornicial pulsations would be. It is called Osiander sign. Again, 8 week onwards. Osiander sign. Softening of cervix would be. Come on, tell me. Softening of cervix is called which sign? It is called Goodell sign. It is from 6th week. Yeah. Goodell sign is from 6th week. Don't forget. Softening of isthmus would be Hagar sign. Hagar sign is from 6 to 10 weeks. Hagar sign. And then there is an option called asymmetrical uterus. Kahan gaya? You are able to see, na? Asymmetrical uterus. I would write the name of asymmetrical uterus as Piscasek sign. Asymmetrical uterus should be Piscasek sign. Okay. Piscasek sign. It is due to lateral implantation. Yeah. Piscasek is lateral implantation. Okay, got it? There is one sign called as Palmer sign. Palmer sign is, yes, what is Palmer sign? It is regular, rhythmic, uterine contractions. 4 to 8 weeks. Palmer sign. 4 to 8 weeks, regular rhythmic uterine contractions. Okay. So these are the signs of pregnancy. Next question. We have covered Apla syndrome, so thankfully you will be able to answer. Which of the following conditions does not warrant Apla testing? One of the following does not warrant Apla testing. You tell me. Arterial thrombus and cerebrovascular accident. 3 or more first trimester pregnancy losses. Early onset severe preeclampsia or gestational diabetes. Obviously the correct answer is gestational diabetes mellitus, but they should have written early onset preeclampsia IUGR causing preterm delivery in less than 34 weeks. Yeah. So gestational diabetes mellitus has nothing to do with Apla testing. Right? We don't do Apla testing in those cases. Okay? Apla testing is not done in JDM. Alright. Next question. The following appearance is seen in. Now this is very simple. Options are ectopic, partial mole, complete mole and embryonic pregnancy, and I'm very sure you people will be able to answer me. You have seen it all. ये तो हम लोग day in and day out करते हैं. What is this? Come on guys. This is very, very easy. You are postgraduates now. Tell me, if you do a sonography, I hope you know sonography कैसे करते हैं. Yeah, transvaginal sonography सबको आनी चाहिए. Everyone should know transvaginal sonography. If you do not know, please learn it. Do a course. May you do super specialization, sonography will always be useful. Yes, tell me. What's this appearance called? This is called as ring of fire appearance. Ring of fire appearance. Yeah. What's the diagnosis? It is ectopic pregnancy. Yeah. This is fallopian tube, ectopic pregnancy, ring of fire appearance. Okay. Got it? My dear friends, but one word of caution. If you get a twisted question, and the twisted question is ring of fire appearance is seen in A. Ectopic, B. Corpus luteum, C. Both of the above, D. None of the above. You please pick up both. Corpus luteum में भी दिखता है ring of fire, but उसका location ovary रहता है. Yeah, ring of fire appearance is seen in corpus luteum as well. Here the correct answer is ectopic pregnancy, no doubt about it. Yeah, this is ectopic pregnancy. All right, आगे बढ़े. Next question. Earliest site, we have covered this. Earliest site to get ruptured in ectopic pregnancy. What's your answer? Earliest site to get ruptured in ectopic pregnancy would be isthmus. Ampulla ruptures 8 to 10 weeks. Interstitium would rupture at 14 weeks and beyond. So the correct answer is isthmus. Infundibulum generally doesn't rupture. Yeah, got it? Very clear. Isthmus is the right answer. We have done this. Next question. 23-year-old primi gravida has 8 weeks of tubal ectopic. Okay. There is no symptom or sign of rupture. USG suggests your minimal free fluid. Remember, free fluid 100 cc or more in pouch of Douglas. Do cultosynthesis to know rupture. To know ruptured ectopic is present or not. Here it is less than 20 ml. Yeah, patient is vitally stable, na? So we will do cultosynthesis only if free fluid is 100 cc or more. यहाँ पे नहीं. Pouch of Douglas में less than 20 ml है. Gestational sag is 2.5. Cardiac activity is not visualized. Beta HCG is 12560 international unit per liter. What is the most appropriate management? Come on, guys. What is your most appropriate management for this patient? Let me see. How many of you know this? Yeah, tell me. Which patient should go for medical management? Which patient should go for surgical management? This patient is candidate for medical or surgical? Here the options देखो. Repeat beta HCG after 2 days. That's bad. No, we will not do that. We know that there is a tubal ectopic pregnancy present. फिर हमें wait and watch policy की जरूरत नहीं है. Yeah. Then your doubt should be between medical management and surgical management. Most of you are writing medical management. The correct answer is actually surgical management. Why? Because beta HCG more than 5000 international unit per liter requires surgical management. Less than 5000 international unit per liter medical management. Remember this. Yeah. वैसे तो figures are different in different textbooks. Williams ने अलग दिया है, right? But you read the Sterox, you read ACOG guideline में भी I think 5000 value दिया हुआ है, but Sterox में तो definitely 5000 दिया हुआ है, right? So if beta HCG is 12,560, it is way more than 5000, so it is advanced pregnancy, and in such cases we don't do medical management. We don't do medical management. Number one, unstable patient. We don't do medical management in gestational sac more than 3.5 cc, 3.5 cm, centimeter. Gestational sac more than 3.5 centimeter if cardiac activity is present. Number three, we don't do if gestational sac is more than 4 centimeter if cardiac activity is absent. So 3.5 for cardiac activity present and 4.0 if cardiac activity is absent is the critical cutoff. You can't do medical beyond that. Yeah. Then the fourth number, beta HCG more than 5,000. We don't do medical management. We do surgical management. Yeah. And any contraindication to methotrexate therapy, we don't do medical management. Yeah. Any contraindication to methotrexate, you better do surgical management. And since she is primigravida with unruptured ectopic, the surgery would be laparoscopic. I told you stable patients का laparoscopy करेंगे. Salpingostomy. Yeah. Fallopian tube को incision करो, open it and remove ectopic. Never ever close the fallopian tube. If you're closing it, it will be called as salpingotomy. You know that. We don't close it. Suture material डालते ही नहीं है. Leave it. The nature will cover on its own. Yeah. I'm very sure आपके हॉस्पिटल में सबका ही salpingectomy करते होंगे, है ना? ट्रेनीज को, फर्स्ट ईयर्स वालों को सिखाते हैं हम लोग, सेकेंड ईयर्स वालों को सिखाते हैं, कर दे salpingectomy, बट गलत है. If patient's family is not complete, you should do salpingostomy. Yeah. So remember, this patient is for laparoscopic salpingostomy. Am I clear about this? Yeah. Next question. Most common cause of ectopic and highest risk of repeat ectopic is with. Now this is informative. There are many risks of ectopic, but most common cause is pelvic inflammatory disease. PID. Yeah. Highest risk is with previous ectopic followed by previous tubal surgery. Williams gynecology में previous tubal surgery लिखा हुआ है highest risk, but this is previous ectopic as the right answer. Radhika is writing, sir, injured tube prone for ectopic later once again. That's true. That is very, very true. Radhika, you are right. But try to understand that most common cause is PID. Yeah. Most common cause is PID, and PID is bilateral disease. So it is quite possible that her other tube might already be blocked. This might be the only functional tube for her. Yeah, Radhika? This might be the only functional tube in her. That is why we always save the fallopian tube in primees. Okay. So yes, remember, most common cause is PID, and PID is the bilateral disease. It is quite possible that she might have a tubal block on other side. So always save the tube if it is not ruptured. Okay. Got it, Radhika? Understood? आप आर्ग्यू कर सकते हो, सर उसके बाद तो आईवीएफ कर सकते हैं ना, बट देन कॉस्ट, राधिका, अंडरस्टैंड, कॉस्ट इज सो हाई. IVF pregnancy is not an acceptable option for many couples. Yeah, they don't have money. At least इनका ये ट्यूब काम तो करेगा. हाँ, you are right, risk of ectopic है 28%, 35% risk of ectopic है, but 65% normal का भी चांस है ना. Okay, that's why highest risk of ectopic is with previous ectopic and then with previous tubal surgery. Okay, then there is something called heterotropic ectopic, which means there is pregnancy inside the tube and pregnancy outside the tube. I had one patient, she was assistant professor in KEM hospital, and she underwent IVF pregnancy, and it was seen in sonography as intrauterine gestational sac seen, and she was happy, she was very, very happy, family happy, ekdam sab khush, everyone was happy. And one night in my emergency duty, she came with syncope and collapse. I examined her. I found free fluid clinically. Yeah, syncope and collapse. Her pulse was very, very feeble. Her pulse was tachycardia. BP was very low. So I thought that this is ruptured ectopic. So I told her we will take her for ruptured ectopic treatment. We will do laparotomy and salpingectomy. The relatives were not ready. They were saying, no, we have done a sonography. We know that it is intrauterine pregnancy. How can you say it is ectopic? Our radiologist is very nice. We have seen it and done it. Intrauterine pregnancy को आप कैसे कह सकते हो heterotropic है? Then I said, intrauterine को कैसे कर सकते हो? Ectopic है. Then I said it could be heterotropic pregnancy because heterotropic का most common cause is IVF. Yeah, IVF. I wanted to take this patient directly to operation theatre and operate, but they were, adamant. Okay, we want to get a sonography, repeat sonography done. I said, okay, your wish. Doctors are the worst patients, है ना? So they took the patient. अभी मैं पूरा crystalloids दबा के दे रहा हूँ. She was assistant professor. I had to be, vigilant over there. It would be a very big issue if something happens to her. Then blood group cross matching वगैरह सब किया. I told my operation theatre people to be ready. I will bring this patient. Sonography में क्या पूरा free fluid, full free fluid. I said, what else do you need? This is a case of ruptured ectopic, heterotropic. So they gave a consent. Then I did an operation and I did a salpingectomy. Heterotropic ectopic treatment is salpingectomy. Yeah, if patient is unstable because of rupture, laparotomy. If patient is stable, then you do laparoscopic. Yeah, am I clear? So yes, most common cause of ectopic is PID and highest risk of repeat ectopic is with previous ectopic. Okay, got it? Which of the following is incorrect about complete mole? Now we have done this. You will be able to answer this for sure. Highest risk of malignant transformation. Has highest risk of malignant transformation. Has high risk of malignant transformation more than partial mole? Yes. Complete mole has 15 to 20% risk. Partial mole has 2 to 5% risk. Uterus is more than period of gestation in most cases. Yes, that's also true. P57 is negative. That's true. Most common symptom is passage of grape-like vesicles. No. Most common symptom is vaginal bleeding. Passage of grape-like vesicles would be most specific symptom. Most specific symptom would be passage of grape-like vesicles. Yeah? Okay, am I clear? Chalo, next question. Abhi we have done partial mole as well. Which of the following is correct about partial mole? Malignancy potential is less than complete mole. Yes. Diffuse hydropic changes are seen in uterus. Diffuse hydropic changes are seen in complete H mole. Yeah. Gold standard is USG. Yeah. Gold standard is histopathology. Most common symptom is hyperemesis gravidorum. No vaginal bleeding. So the correct answer is A. They have asked about correct. So 36A. पिछला क्या था? मैंने कुछ गलती किया क्या पिछले में? Which of the following is incorrect पूछा है ना? या इनकरेक्ट है तो 35 का आंसर है डी. करेक्ट पूछा है तो देयर वुड बी ए. इन पार्शियल मोल देयर इज फोकल चेंज, focal placental hydropic change. Do I have the sonography of partial mole? I think I have. That question would come. That question of sonography of partial mole would come. I don't want to reveal it right now. Next question. Now this is if you have read Williams obstetrics well, you will get to know. Match the following conditions in fetus. Fetal insulin in plasma, lanugo in skin, embryonic movements and breathing in fetus. When does fetal insulin appear in plasma? In plasma it appears at 12 weeks. याद रखना. Yeah? प्लाज्मा में 12 वीक्स, पैनक्रियाज में 10 वीक्स तक आ जाता है, प्लाज्मा में 12 वीक्स. या Lanugo in skin. Lanugo hair would be seen by 16 weeks. Embryonic movement, 7 weeks. Yeah. And breathing, 11 weeks. Breathing is 11 weeks, correct. Breathing is chest wall movement. Yeah. Urine formation, 12 weeks. Swallowing, 10 weeks. Swallowing, 10 weeks. Mullerians and Wolffian, they appear at 6 weeks. Mullerian, Wolffian will appear at 6 weeks. Yeah, one will disappear at 9 weeks. One will disappear at 9 weeks. Mullerian, Wolffian will appear at 6 weeks. Okay, so here insulin का 12, मतलब 1 का है D, 1D. 2 का है Lanugo 16, 2D, 1B, 2D. 3 embryonic movement, 7 weeks, 3C and 4A. So correct answer is A. Okay, these are informative things about the weeks of gestation. When is quickening? Quickening is seen in primary at 18 weeks, multi at 16 weeks. Primary 18, multi 16 weeks, slightly earlier. Yeah, there's something called lightening. It happens in primary at 37 weeks and multi just before labor. Yeah, multi just before labor. Got it? Quickening happens earlier in multi. Lightening happens earlier in primary. Next question. Okay, 32-year-old with 19 weeks of gestation, primary gravida. Primary gravida, 19 weeks of gestation, has undergone level 2 scan, which is also called a TIFA scan or congenital anomaly scan. It has revealed single umbilical artery in umbilical cord. There are no other significant findings. Her previous antenatal visits and investigations were normal. What should be your opinion in this case? Come on, this is a very practical thing. कितनी बार आपके ओपीडी में पेशेंट्स आते हैं, they show sonography and they tell doctor what to do, what should we do? There is single umbilical artery written by radiologist, nothing else, बस single umbilical artery दिखा रहा है. Yeah, umbilical cord में 3 vessels रहती है. You know that if there is one artery missing, it is called single umbilical artery. So double vessel cord भी बोल सकते हो, double vessel cord. तो क्या करना चाहिए? Tell me. To undergo amniocentesis for risk of Down syndrome due to single umbilical artery? Yes, single umbilical artery is a soft tissue marker for Down syndrome. But I would say this is not the right answer. To undergo amniocentesis for the risk of Down syndrome due to her age? No. Reassurance or to do chorion villus sampling and karyotype? What is your answer? The correct answer is reassurance. 38 का correct answer is C. Remember this line. Isolated single umbilical artery. Acha, Radhika is playing safe. A or C? No. You have to give me one answer. The answer is C. Isolated single umbilical artery would be reassurance. But if there is isolated single umbilical, if there is single umbilical artery given over there, what next पूछा है? Single umbilical artery, what next? So you will have to do पूरा anomaly scan. Yeah, and if anomaly scan is gross congenital anomaly, do MTP. Gross congenital anomaly, do MTP. Yeah, you are seeing cardiac disease, you are seeing neurological, GI, gross congenital, कुछ भी दिखता है ना, we do MTP. If there is any other soft tissue marker, like echogenic cardiac focus, like echogenic bowel. That means there are now two soft tissue markers. One is single umbilical artery and other soft tissue marker. You will have to do amniocentesis followed by karyotype. You understood that if patient has single umbilical artery, tell her to get the malformation scan. अच्छी जगह से malformation scan करवाओ. Gross congenital anomaly आएगा तो MTB करना है. Nothing else आया तो reassurance करना है. Any other soft tissue marker आया तो amniocentesis karyotype. Amniokaryo करना है. Yeah? Am I clear? We are talking about second trimester. Here we do amniocentesis. Okay? First trimester की बात नहीं है, second trimester की बात है. Amnio can be done. Amnio is not allowed in first trimester. Okay? Am I clear about this? Radhika? इसका आंसर होगा reassurance. Okay? Next question. Yeah, we have covered this. We will not talk about it further. Implantation occurs on lateral wall of uterus instead of posterior wall. Then what is this sign called as? If implantation happens on the lateral wall of uterus, then it is called as Piscaseck sign. We call this pregnancy as angular pregnancy. Radhika is asking, sir, are these babies normal after birth? Yeah. Radhika, believe me, though the risk of congenital malformation is increased, but that risk is not 100%. Yeah, believe me, 55% cases will be found in normal pregnancies. Yeah, single umbilical artery, 55% normal pregnancies. Yeah, in fact, of all normal pregnancies, 0.5% inbuilt risk is there with all normal pregnancies. Yeah, you understood two different lines. Single umbilical artery, 55% are normals. Yeah, CVS anomalies may be there, GI anomalies may be there, then GU anomalies may be there. CVS के बाद GU आता है, genitourinary. Normal pregnancy 200 में से एक को single umbilical artery होती है. अरे, my cousin's daughter had single umbilical artery and nothing else. I told, don't worry, do nothing. Yeah, and baby was born normal, baby had no problem, baby was all fine. Had there been soft tissue marker, I would have told them to go and get the amniocentesis. Yeah. So nothing happens. Single umbilical artery is seen in normal pregnancies as well. वैसे diabetics में बढ़ जाता है risk. Diab में बढ़ जाता है, twins में बढ़ जाता है. Risk is increased. Roughly 2.5% in twins, 5% in diabetics should be single umbilical artery. Yeah, you should know this. Acha, I was talking about Piscaseck sign. This is angular pregnancy. My question to you is this normal pregnancy? Yes or no? Yes, it is normal pregnancy. Once the patient will become 14 week, uterus is occupied completely. 14 week uterus is completely occupied. So there will be nothing called, Piscaseck sign after 10 weeks, by the way. So angular pregnancy और cornual pregnancy में फर्क है. Yeah, angular pregnancy, cornual pregnancy में फर्क है. Thank you, Radhika. Yeah, listen. I talked something about cornual pregnancy, है ना? Cornual pregnancy is in the cornual part of fallopian tube. So there is an ectopic. Yeah, it's called cornual ectopic. It's there in the part of fallopian tube. Though fallopian tube is in uterus, but it is there in the fallopian tube. Now, how do you know the difference between angular and cornual? Remember, round ligament तुम्हें बताएगा whether it is normal or abnormal. Think about it. Imagine my hands as fallopian tubes, and this fallopian tube arises from cornu of the uterus. Yeah? उधर से ही राउंड लिगामेंट आगे जाता है, पीछे ओवेरियन लिगामेंट जाती है. Now suppose if there is intrauterine pregnancy called angular pregnancy. Angular is intrauterine. The round ligament would be lateral to it. Yeah? Round ligament would be lateral to it. Yeah? And अगर cornual ectopic है, The round ligament would be medial to this mass. So sonography में we see that ये mass कहाँ पे है. If we are able to identify, though round ligament identify करना भी difficult होता है sonography में, but remember this thing. Angular pregnancy is normal pregnancy. Cornual pregnancy, ectopic is ectopic pregnancy. Round ligament tells the radiologist कि भैया this is intrauterine or not. Okay. So round ligament tells you the truth. याद रखना. Round ligament is medial to cornual ectopic, lateral to angular pregnancy. Okay. Am I clear? Okay. 34-year-old patient with gestational choriocarcinoma, which was limited till uterus, with no metastasis to any organ. Prognostic score 4. She wants to retain fertility for future childbirth. What should be the treatment of choice? This we already covered. Yeah, we have covered this. There is a patient with prognostic score of 4. The answer has to be single drug chemotherapy. My question to you is, who all are for surgery in GTN? The answer would be A, if family is complete. And surgery would be obviously hysterectomy. Family complete, you do hysterectomy. May that be patient of 34 year age or 26. Family complete, you do hysterectomy. B, perforation of uterus. Perforation of uterus by invasive mole, you should do hysterectomy. Then you are saving her life. Uterine rupture हो गया, you will save her life. फिर प्रेगनेंसी चाहिए तो नहीं होगी, सेरोगेसी करना पड़ेगा, but that's okay. Perforation के लिए we will have to do surgery. Then PSCTs and epithelioid trophoblastic neoplasias are chemo-resistant cancers. They require surgery. So they require surgery. Okay. Am I clear? Yeah. So if there is rupture of uterus, you have to control the bleeding. You will have to do hysterectomy. Am I clear about this, guys and girls? Now, who all will require radiotherapy? Radiotherapy is basically for brain metastasis or liver metastasis. We generally prefer radiotherapy over there. We give chemotherapy, but brain metastasis, liver metastasis would additionally require radiotherapy. Okay, got it? Very clear? आगे बढ़े? चलो, next question. Okay, big question coming your way. Yeah, Asha is writing sepsis, high uterine, intrauterine tumor load. Of course, yes. If there is infection and antibiotics, generally we try antibiotics. Or antibiotics not getting the control, obviously we have to resort to hysterectomy. ये तो हम लोग कभी-कभी तो PID with not responding to antibiotic therapy and pus in uterus, pyometra in uterus को भी hysterectomy करते हैं ना कभी-कभी. Yeah. So yes, hysterectomy is a component of management of even infections. Okay. Yes, Asha, you are right. Chalo, let's talk about another case. 29-year-old patient who had primary infertility, took 4 months of antitubercular therapy and she conceived during the course of antitubercular therapy. Okay, which is actually 6-month course. We all know genital TB requires 6 months of HRE and obviously initial 2 months add Z as well. So HRE Z for initial 2 months and HRE for the remaining 4 months. She does not remember her last menstrual period since the periods were irregular. On examination, uterus is of a size of hen's egg. Hen's egg, मुर्गी का अंडा, 6 week. 8 week होता है cricket ball. 12 week size होता है fetal skull. चलो खैर, hence egg size है. Bilateral head necks are normal. Okay, fine. USG suggests your double bleb sign. Double bleb sign. with gestational sac 20 millimeter. So there is 20 millimeter gestational sac. Yeah, 20 millimeter gestational sac, and there is yolk sac also there. There are no fetal poles, no cardiac motion. What should be the best plan of action for her? No fetal poles, no cardiac activity. But I would say this is gestational sac 20. I told you critical cutoff is 25 millimeter for crown rump length. So is this early pregnancy? Yes, indeed. This is early pregnancy. What should I do? A, repeat USG after 1 week and continue ATT, or do serial beta HCG and continue ATT. Tell her to undergo MTB because 2 months of ATT is still pending. Tell her this is a missed abortion since there is no fetal pole, and continue her ATT after suction evacuation. The correct answer has to be A. Repeat USG 1 week later and do ATT continuously. ATT is safe in pregnancy except for streptomycin, which we don't give. हम लोग स्ट्रेप्टो तो देते ही नहीं है ना, जेनाइटल टीबी को स्ट्रेप्टोमाइसिन नहीं लगता है ना. So we will do repeat USG, and 1 week later we are going to do repeat USG, and ATT should never be stopped. कोर्स कंप्लीट होने तक ATT चालू रखना है, as simple as that. ATT is safe in pregnancy. Okay. Which antibiotics are safe in pregnancy? Yes, Radhika, ATT is safe in pregnancy. You're right. Which antibiotics are safe in pregnancy? याद रखो PCN, penicillins, cephalosporins and macrolides. I repeat, penicillins, cephalosporins and macrolides. Even nitrofurantoin is safe. Yeah, nitrofurantoin is safe. Even metronidazole is safe. These are safe antibiotics in pregnancy. Bacterial vaginosis होगा तो क्या दोगे? Metro ही दोगे ना? Secnidazole, metronidazole, these are safe. Yeah. Chlamydia होगा तो क्या दोगे? Chlamydia trachomatis. Azithromycin, azithro is safe. Neisseria gonorrhea होगा तो क्या दोगे? Ceftriaxone or cefixime, both are safe. Yeah, so these are safe antibiotics in pregnancy. Okay, am I clear? Next question. Which of the following investigations is not necessary in case of patient who has had history of second trimester abortions in all 3 pregnancies in past? So T2 abortions multiplied by 3. 3 T2 abortions. Tell me, what will not be the cause? Which of the following is not necessary? Can Apla syndrome do it? Yes, of course. Can translocations do it? Yes, of course. Thyroid profile? Yes. But Torch titers? No. I have told you, once patient gets infection, she becomes immune to that infection and there will be no chance of recurrent pregnancy losses. You may argue, sir, what if there is toxo first, then rubella, then cyto, then herpes, 4 abortion हो गए ना सर? No. Remember this thing. ऐसा होना नहीं चाहिए, ऐसा होता नहीं है, but हुआ भी तो हमें क्या फर्क पड़ता है? We are not going to investigate because our treatment modality does not change. एक बार रूबेला हो गया, फिर क्या मैं टेस्ट करूं रूबेला का? या शुड आई चेंज? आई मीन मैनेजमेंट कुछ चेंज हो जाएगा? नहीं होगा. टॉक्सो हो गया, आईजीजी पड़ा है तो पड़ा है, उससे मैनेजमेंट चेंज नहीं होगा. या our management does not change whether torch is positive or negative. Okay, that's why torch titers are useless. Again, big question, but I think I have covered this question already. Yeah, G2P1L1, 13 weeks of gestation, passage of grape-like vesicles. There is snowstorm appearance. She is subjected to suction evacuation. Her baseline is 85,000. Which of the following is incorrect regarding further management? So she is a complete mole. Complete molar pregnancy. I have done a suction evacuation for her. So what do I do? Weekly beta HCG till it is undetectable, and then monthly for how many months? Monthly for 6 months, and combined ossiples for contraception. The correct answer, we have done this, so I will not repeat it again. The correct answer has to be C. Monthly beta HCG for 6 months, combined ossiples for contraception. By the way, what was I telling? कुछ तो किसी ने क्वेश्चन पूछा, राधिका ने क्वेश्चन पूछा. I was reading that. अच्छा, I will talk about Radhika's question, but try to understand this thing. Once it is undetectable, you have to still do weekly for 3 undetectable values. Then you do monthly. Radhika is writing, sir, spiramycin is given to treat toxoplasma patients. No, spiramycin is useless. Let me tell you that. In obstetrics, we don't use spiramycin. No, not at all, Radhika. No, we don't treat let's say toxo IgG positive है, तो वो तो immune है ना. टॉक्सो आईजीजी पॉजिटिव है तो इम्यून हो गई ना, राइट? और टॉक्सो आईजीएम भी पॉजिटिव है तो डैमेज तो ऑलरेडी हो चुका है. स्पायरामाइसिन से कोई फायदा नहीं होता. या वो जो एमआरस लोग आते हैं ना स्पायरामाइसिन लेके, उन लोगों को तो मैं उधर से ही भगा देता हूँ. प्लीज गेट आउट ऑफ माई ओपीडी. योर ड्रग इज यूजलेस. व्हाई आर यू डूइंग वियर्ड थिंग्स? Spiramycin is not used. Okay, got it? Approximately what percentage of spontaneous first time abortion show chromosomal abnormalities? I told you this thing. Spontaneous abortions showing chromosomal abnormalities would be 50%. The range is 25 to 50, but remember 50 is the right answer. Yeah? Studies, कोई कुछ बताता है, कोई कुछ. Williams ने clearly बोला 50% are anomalous. I mean chromosomal abnormalities. That is what you should pick up. Which of the following is correct होना चाहिए ना? I'll change the question. Which of the following is correct regarding further management? Yeah, it is not incorrect. Which of the following is correct? Okay. How can be there multiple correct answers? है ना? So you'll have to do subjected to weekly beta HCG till undetectable, then monthly for 6 months, and then combined ossipals for contraception. Thank you so much. I'll correct this. This is correct. Which of the following is correct regarding the treatment? Thank you, PS. I'll correct that question. Okay. This question was already there, I guess. I guess this is a repeat. Next question. 26-year-old, Gravida 3, Para 2, Living 2 has come with 12 weeks of gestation. Frequent vomitings, restlessness, heat intolerance, मतलब thyroid toxicosis भी हो सकता है. Her pulse is 114, low volume, BP is 100/60, uterus is of 16 week size, intrauterine hypoechoic multiple 2 to 3 centimeter vesicles. Which of the following is not correct? Again, same type of question. Which of the following is not correct? Patient should undergo suction and evacuation followed by sharp curettage. Yes, this is correct. Risk of development of malignancy 2 to 5%. No, this is not correct. Most common karyotype is 46XX. That is correct. Radhika, no. Toxo IgM मैंने बताया ना, toxo IgM भी होता है ना, तो spiramycin has no role. Not at all. It has no use in obstetrics. As simple as that. Okay. Hyperthyroidism and hyperemesis will subside after suction evacuation. Yes. Because the source is HCG. Okay, source is HCG. Okay, am I clear? चलो, ये question तो हमारा हो गया है, so we are not spending much time on this question. Next question. I think we have done this also. 33-year-old, Gravida 3, Para 2, Living 2 with 30 weeks of gestation. With previous full-term normal delivery was incidentally diagnosed as a case of short cervix. With cervical length of 1.5 centimeter. There is no other obstetric high risk. She has G3P12 with 30 weeks right now. Yeah? Which of the following is correct treatment plan for her? एक तो सर्कलास तो करने का टाइम भी नहीं है और आइसोलेटेड शॉर्टनिंग ऑफ सर्विक्स में करते भी नहीं है. या अब बात आती है प्रोजेस्टेरॉन या टोकोलाइटिक्स. इज दिस पेशेंट हैविंग यूटेराइन कॉन्ट्रैक्शंस? The answer is no. She is not a preterm labor case. सो प्री टर्म लेबर के केस में प्रोकोलाइटिक देते, यहाँ पे तो वो नहीं करेंगे. सो नो प्रोकोलाइटिक्स, नो सर्कलाज. The correct answer has to be 17-hydroxyprogesterone injections. Yeah, some people give it till 34 weeks, some people give it at till term. There are studies supporting both of these things, right? I generally give it till 37 weeks because nowadays we say anything below 37 is a risk. In fact, anything below 39 is a risk. Yeah, so at least 37 तक तो देना चाहिए progesterone weekly injections. Yeah, okay. Guys, girls, so correct answer is D, 17-hydroxyprogesterone. Next question. 25-year-old, Gravida 2, Para 1, Living 1 has 12 weeks of gestation. Early pregnancy here. NT scan shows 3.8 millimeter nuchal translucency. Her DIPSI test is suggestive of value 208. Dual marker test is within normal limits. So beta HCG and PAPA are normal. Which of the following things should be included in the management of this patient? Come on, tell me. What should I do for this patient? Is she screening positive? Yes, she is. The critical cutoff is nowadays considered as 3 millimeter. Yes, so she is screening positive. 12-week pregnant patient. We will do chorion, villus, sampling. Chorion, villus, sampling. We will do chorion, villus, sampling. Okay, my question is DIPSI test. Is DIPSI test used for detection of diabetes? Yes, sir. At 12 weeks? Of course, yes, sir. In India, we are doing it at 12 weeks, first visit, and also at 28-week visit. Yeah. The value is 208. So she is a clear-cut case of overt diabetes mellitus. Overt diabetes mellitus cannot be treated by metformin. You can't give metformin. The only thing which you can give is insulin. So give her insulin, correct her blood sugar level, and then go for chorion, villus, sampling. That's the plan of action for this patient. So chorion, villus, sampling has to be done, plus insulin control needed. Okay, she is a case of overt diabetes mellitus. Alright, am I clear? Can there be congenital anomalies? Yes, sir. Anomalies can be there. Overt diabetes mellitus, anomaly risk is directly proportional to HbA1c value. It should be ideally less than 6.5% before attempting pregnancy. Less than 6.5 before pregnancy. During pregnancy, it should be less than 6. HbA1c during pregnancy should be less than 6. Most common system anomaly, CVS anomaly. Most common system anomaly, CVS. Most specific would be sacral agenesis. Most specific would be sacral agenesis. Okay, got it? Very clear? Alright, so this is about the question number 47, right? Next question coming your way. 32-year-old priming gravida has undergone this test. Read the test and pick up the incorrect statement. Okay, let us first read the test. Okay, let me first show you this picture without Anil Mirchandani in this picture. Okay, have a look at this test. Think. What is given? ये तो आप लोग देखते हो. हम लोग पहली चीज देखते हैं वो ये ग्राफ देखते हैं, है ना? It is in the green zone. So low risk patient. Yeah. This is a Down syndrome dual marker screening. Dual marker screening है. What is written? PAPPA 4.2, multiples of median 1.0, pre-beta HCG 115, multiples of median 3.11. That's free beta HCG. Nuchal translucency 1.1. So NT scan is normal. Yeah. She does not have twin gestation. कहीं पे लिखा नहीं है twins. Number of fetal. हाँ 1 लिखा हुआ है. Previous history of trisomy 21 unknown लिखा हुआ है. Somebody has done this test. मतलब previous history of trisomy तो नहीं होना चाहिए. We don't do this test if patient has previous history of trisomy, right? Trisomy risk is 1 by 998. So it's a low risk. Why? Because for 21 trisomy, the risk ratio 1 by 250 is positive. 1 by 250 is cutoff. 1 by 250 is the cutoff. Okay. For Edwards syndrome, Down syndrome, 1 by 100 is cutoff. Yeah, for Edwards syndrome, Down syndrome, 1 by 100 is cutoff. Age risk be 1 by 460 hai, so that is not necessary. Okay. Okay. So what do you say? Which of the following statement is correct? I hope you have understood the question. Pick up the incorrect statement. Okay, the question is about incorrect statement. Incorrect statement. Her NT scan result is normal. Yes, 1.1 is normal. Her value of PAPPA is normal. Yes, it was MOM 1.0. Her free beta HCG is normal. No. Her MOM is 3.11, which is very high. But even with this high value, her screening has come out as negative. What was the risk ratio? Risk ratio was negative 1 by 998. So she was negative. Follow up routinely. Nothing else has to be done in this case. So the correct answer is this, C. Though beta HCG is high, but her values are not that high to be labeled as screening positive. So the correct answer is 48C. Did you get it? I hope you did. यहाँ पे आपको slide पे दिखाया correction of MOM is 3.11, which is very high for beta HCG. Yeah, anything more than 2 is significant, right? It is more than 3 times MOM. So it is significant. Alright. So my dear friends, this patient's beta HCG is not normal. Even if it is not normal, the ratio is coming as normal, so we don't do anything else. Okay. Got it? Very clear? Alright. After this question, let us take on another question. The correct gestational age for assessing the following USG finding between the two marked point is. So no question. Correct gestational age for assessing the following USG finding between two marked point is. So let's see the USG. Oh yes. This is which sonography? This is called as NT scan. Nuchal translucency scan. The fetal head. Fetal head should be in neutral position. Neither flexed nor extended. Away from amnion. Sagittal view. Sagittal view. And you are measuring the distance between the fluid filled space. This is NT scan, nuchal translucency scan. This is done between 11 weeks to 13 plus 6 weeks. This is the first trimester screening. Yeah, this is first trimester screening. यहाँ पे nasal bone भी दिख रहा है. But nasal bone is first and second trimester both. NT scan generally is the first trimester screening. It is combined with beta HCG and PAPA to make it as a combined screening. Yeah, and combined screening sensitivity is 85%, false positive 5%. Combined screening sensitivity 85%, false positive 5%. Regarding quadruple, regarding quad test, the answers would be 80% and 5%. 80% and 5%. Sensitivity, 80% and 5% is false positive. Regarding NIPT, 99% and less than 0.1%. That's why NIPT is so wonderful test, but it is very costly. Those who can afford will afford, can do it. But then NIPT is a very costly test. It just gives me about the DNA makeup of the baby. Regarding combined, it gives me this the advantage of combined is that we see the sonography as well, right? Advantage of quadruple marker test is that alpha fetoprotein is raised in neural tube defect, so that is also covered by quadruple marker test. Quad test has alpha fetoprotein, free beta HCG, unconjugated estriol, and inhibin A. These four things are there in quadruple marker test. So there is alpha fetoprotein which is raised in neural tube defect. So this is another advantage of quadruple marker test which is not there for NIPT. So NIPT has its own merits, but quadruple will be having its own merit that it is useful for screening neural tube defect as well. For combined screening, we do sonography. Sonography has its own merits that we assess the morphology of the baby as well. Yeah. So the correct answer to this question has to be 11 to 13 plus 6 weeks. 11 to 13 plus 6 weeks. Am I clear about this? Yeah. Next question. Big question again. 32-year-old, G3B2L2, 18 weeks of gestation, pain in abdomen since last 2 weeks. She's having pulse of 82 per minute and BP 110/70. So vitals stable. On per vaginal examination, uterus is 6 weeks, deviated to right side. Uterus is 6 weeks, deviated to right side. Okay, there is large left adnexal mass of approximately 10 centimeter size. Okay, so uterus is deviated to right side and there is a large adnexal mass of 10 centimeter size. Yeah, it reveals fetus of 18 weeks. So there is an ectopic pregnancy. It reveals fetus of 18 weeks in pouch of Douglas with formed placenta on the mesentery. What should be the mode of treatment? So this is abdominal ectopic. This is a clear-cut case of abdominal ectopic. What should I do? Should I continue pregnancy till 34 weeks and then do exploration? Never. Abdominal ectopic is life-threatening. Immediate treatment is needed. Immediate treatment is needed. Give injection methotrexate? No, it is advanced pregnancy. Abdominal ectopic, you should do only treatment as surgery. There is no medical management of this patient. Yeah. USG guided KCL injection in the heart of fetus? Obviously no. You won't do this medical management. Exploratory laparotomy with delivery of fetus but leave the placenta in situ is the correct answer. Remember this line. Never remove placenta in abdominal ectopic case. Yeah. Never remove placenta from the body in abdominal ectopic case. Let it be there. It is very dangerous to remove because it will cause profuse bleeding which would not stop and the patient would die. So remember, abdominal ectopic, never remove placenta. Let it be. It will autolyze and the patient will live happily ever after. Yeah, there is, I told you, Study-Ford criteria in abdominal ectopic. Study-Ford criteria. It says I'll use another page for it. Give me 1 second. Study Ford criteria says that number 1, there should be intact fallopian tube. By the way, study Ford is for primary abdominal ectopic. Intact fallopian tube and ovaries. Number 2, no utero-peritoneal fistulae. No utero-peritoneal fistulae. Number 3, implantation over peritoneal surface. Implantation over peritoneal surface. So these are 3 things which will make it primary abdominal ectopic. Yeah? Am I clear? Study Ford criteria. Okay. So that was our, I think, 50th question. The story is not yet over. We have some more questions. I made few more questions because there were many repeat questions. I thought that I'll put more. But those repeats are not exactly same repeats. They are like similar questions. 32-year-old, gravida 4, abortion 3 with 6 weeks of gestation, has a history of 3 abortions in past. The abortions were spontaneous at 8 weeks of gestation. Which of the following is not the likely cause? I have told you this thing, that cervical incompetence cannot cause first trimester abortions. That's why this patient cannot be case of cervical incompetence. She could be having APLA, she could be having hypothyroidism, balanced translocation, but not cervical incompetence. Okay. Next question. Again, we have covered this. Threshold for non-viability of pregnancy in first trimester of USG is absence of cardiac activity with crown rump length of 7 mm. We have done this. This is a repeat question actually. Identify this condition. The patient came in 4th month of pregnancy with history of bleeding per vaginum. First, let us see the condition. Okay, what is shown over here? Okay, there is a placenta, there is a baby. This is fetus. Ek minute, let me remove myself from this picture. Yeah, now you tell me. Fetus is there, placenta is there. What else is there? Come on, think and tell. What is your spot diagnosis? Come on. I am able to see placental mass with focal hydropic changes. Grape-like vesicles are there. Obviously, it's a partial mode. Never forget this picture, it's a partial mode. So there are focal hydropic changes. Yeah, this is a partial molar pregnancy. Okay. It's a very, very similar picture to a twin gestation with molar pregnancy and fetus. How to differentiate? Why it is not twin with molar on one side and gestational sac having baby on other side? In this case called partial mole, this baby would be triploid baby. Yeah. So it is partial mole. Okay. Same picture would be there in twins with complete mole on one side, but that option is not there over here. So the correct answer is partial molar pregnancy. Partial molar pregnancy. Okay, got it? Very clear? All right, let us jump on to the next question. 23-year-old primary gravida, married since last 6 months, has history of amenorrhea since last 3 months. Her previous cycles were regular, monthly. She has history of profuse vaginal bleeding since last 4 hours. She has passed fleshy mass 1 hour back. On examination, her uterus is 8 week size. So she is 3 month pregnant. मतलब 12 week के करीब. Yeah. She has history of POC passage. Okay. Uterus is 8 week size. Plus, os is open. Don't you think something is still left behind inside uterus? And uterus is 8 week size cannot be there in ectopic pregnancy. Na? Uterus is 8 week size cannot be there in ectopic pregnancy. Yeah? What is the likely diagnosis? Obviously, the likely diagnosis would be abortion. Molar pregnancies are very rare. Fleshy mass pass किया है उसने, right? Molar pregnancy में भी हो सकता है. But then remember, molars are very rare. Okay? Here the correct answer has to be incomplete abortion requiring treatment called curettage. You'll have to do curettage. Okay? Yes, this is incomplete abortion. We do these things day in and day out. So I don't think this will be a very difficult question for you. This is a case of incomplete abortion. Okay, next question. 32-year-old nulliparous patient. History of 3 abortions in last 3 years. All the abortions were spontaneous and were of 8 to 9 weeks, which is a possible cause. Possible cause. Can it be cervical incompetence? No, I told you it is not possible. Now, syphilis does not cause abortion in less than 18 weeks. So this is also out. Yeah. Balanced translocations and subserous pedunculated fibroid. Believe me, subserous pedunculated fibroid जिसको हम लोग WHO 7 कहते हैं, वो तो यूट्राइन कैविटी को कभी डिस्टॉर्ट कर ही नहीं सकता ना. So this can also never be a cause of abortion. Only submucous fibroids and fibroid distorting the uterine cavity, yeah, can cause recurrent abortions. So the correct answer is C. 55. C is the right answer. Okay, got it? Chalo. Next, so 8 to 9 weeks abortion के बहुत सारे questions we have already done. Yeah, so you should be ready with these questions. Let us talk about the last question. 25-year-old primary gravida with tubal ectopic pregnancy of 6 weeks. She is subjected to single dose therapy. Her beta HCG value is 2500. After 3 days of methotrexate, her beta HCG is 3250. What is the next best line? Now I leave this question up to you. You tell me what's the next best line. I will not explain. Tell me. There was a patient whose beta HCG was 2500. After 3 days, it became 3250. Give injection methotrexate again or repeat beta HCG after 3 days or laparoscopic salpingostomy or PGF2 alpha injection. What is your right answer? Tell me. I'll give you the hint. Should I give you the hint? I feel like I'll give you the hint. Come on, tell me. Write down 56 and give me the answer A, B, C, D so that I can understand आपका answer क्या है. 56A, 56B, 56C, 56D. What do you think is the right answer? Please write down in this format so that I know, okay, you people know. Come on guys, this is your exam question. What will you do? Okay, I'll give you a hint. Acha, Radhika has written repeat after 1 week total. Acha, I have not given 1 week option. I have given repeat after 3 days, Radhika. I'll give you a hint. Do you know day 1, day 4, day 7 protocol? What is called as single dose therapy. Day 1 injection methotrexate day. It is 50 milligram per meter square body surface area IM. Day 4 check beta HCG. Day 7 recheck beta HCG. It should fall by 15%. To consider it as successful, it should fall by 15%. If no, then repeat. Day 1, day 4, day 7 has to be repeated. Yeah, it should fall, otherwise you repeat day 1, day 4, day 7. So what is given over here? Let's see. Her HCG value is 2500 on the day of methotrexate management, methotrexate injection. So day 1 ka HCG 2500 hai. Day 4 beta HCG is 3250. That's okay na. We will repeat beta HCG after 3 days. So the correct answer has to be B. Understand this thing, once the fall has happened, 15% fall ho chuka. If 15% fall has happened on day 7 present, then weekly beta HCG would be done. If it has not fallen, then you will have to repeat day 1, day 4, day 7. Maximum 2 repeats are allowed. Not more than that. If 2 repeats are over, then you will have to proceed to the surgical management called laparoscopic salpingostommy. Yeah, this is a stable patient. Beta HCG 5000 से कम है, medical management कर सकते हैं. We can do medical management. Remember, single dose therapy is the most common medical management. Though multiple dose therapy has high success but high toxicity. That's why single dose therapy is most common medical management for ectopic pregnancy. Okay, so the correct answer of 56 is B. Alright, am I clear about this? This is all about it, guys. Thank you so very much. Asha is asking about, please repeating. Okay. Asha, what did I say? That the patient underwent medical management. Her beta HCG was 2500. That's why she underwent medical management. She was given methotrexate and after 3 days her beta HCG rose to 3250. That is okay because we are still on day 4. The rule is day 7 beta HCG should fall by 15%, 15%. If day 7 falls by 15%, great. We have to do weekly beta HCG after that. That's it. If it doesn't fall, then day 1, day 4, day 7 has to be repeated. Asha is writing HCG should fall, but here it is rising. Asha, day 1 से day 4 rise हुआ तो कोई फर्क नहीं पड़ता, वो तो rise होता ही है. When you kill something, it will blast and it will release HCG. Yeah, you are given methotrexate. On the day of methotrexate, it was 2500. It may rise. That's okay. Day 4 का beta HCG 3250 है. But then, how do you know it is killed? Day 7 will tell you it is killed. Yeah, day 7 should tell you it is killed. If it is killed, it will fall. 3250 का मैं 7th day का example दे रहा हूँ, वो 2000 हो गया. बस 2000. 1225 कम हो गया. So हो गया ना, you have killed the ectopic. फिर क्यों methotrexate देना है आपको? Okay, so correct answer is repeat beta HCG after 3 days. Okay, thank you very much. Thank you everyone, guys. I wish you all the best, and yes, madam is going to take your lecture next week, probably Monday or Wednesday, that madam would tell you. Yeah. So I hope you enjoyed the session. I know it was full of those cases and questions which you oftenly deal with in your clinical practice. But then in an MCQ way, it's a totally different story, na? Just like this beta HCG wala topic and this ectopic topic. What you actually do in MCQ is what you do in your clinical practice, right? But the orientation, the way of treating and thinking about the case is very important. Thank you very much. Thank you for all your wishes, my birthday wishes. Thank you so much. And yes, I feel younger day by day. Okay, and it's all because of you all. Thank you so much. Bye bye. Love you guys. Do well in exam. I'll be there. Obviously, there are few more sessions, and I'll be there. But I will meet you probably next week. Now, next week will be madam's week, and she will take you through to the through to another topic in obstetrics. The day would be decided by madam, and yes, we'll meet soon. Okay, bye bye, take care, good night, see you.